Good afternoon, everybody. My name is Ruth McEwen and I'm Chair of the Health and Wellbeing Board. So thank you very much to everybody for attending, either in person or online. And just before we start the Health and Wellbeing Board today, I have an announcement which I'll be reading out to you. I would like to inform everyone present that this meeting will be recorded and broadcast live in Microsoft Teams and will then be uploaded and available for repeat viewing on the Council's website. You should be aware that the Council is a data controller under the Data Protection Act. Data collected during a webcast will be retained in accordance with the Council's published policy. I'm afraid that due to current technical problems in the Council chamber, not all the members of the board physically present will necessarily be able to be seen on camera, but you should be able to hear everyone if they use the microphones. The seating in the public gallery will not be filmed. Members of the public are only able to speak if they've submitted a formal question in accordance with Council procedure rules. Please could councillors, officers and partners attending introduce themselves before they speak at the meeting for the benefit of the public. And just to help me arrange the meeting, if any members of the board attending online wish to speak during the meeting, please can you indicate your wish to speak by raising an electronic hand in Teams, and also indicate verbally and wait to be called. This will help to avoid missing your request. Those members in the chamber can indicate their wish to speak by raising a physical hand as usual. And when not speaking, all online attendees should put their microphones on mute and switch off the cameras. If called to speak, please switch on your camera and unmute your microphone and pause for about 3 seconds to allow for a slight time delay in connection. Thank you very much. So as I say, welcome everybody to the meeting. So agenda item 1, declarations of interest. Nope. Can't see any. Okay, thank you very much. And agenda item 2, minutes of the meeting held on the 14th of July. Is everybody happy to approve the minutes? Agreed? Thank you. Agenda item 3, questions. We don't have any questions. And number 4, petitions. We don't have any petitions. So moving on then to agenda item 5, the Reading Area SEND Strategy 2022 to 27, an update and progress. And I believe we have Brian presenting and Sarah. Or is it just Brian? Yeah, Brian. Thank you.
Thank you, Chair. So I'm going to do a brief introduction for board in terms of this item. I will then ask colleagues representing Berkshire, Oxfordshire, Buckinghamshire, ICB and Reading Families Forum to speak on this item as well, which is the ethos of our approach that we've had over the last year, 2 years. Members of the board will remember last year that we presented an update that absolutely was centred on exactly that same point, which is around making sure that we are co-productive, that we're working closely hand in hand across the partnership and agencies. We also have a short input in terms of a next step, which we feel is quite critical, regarding the Department for Education delivering better value programme, which board members will see in the paper. Dr. Roxana Glennon, strategic lead for SEND and head of service for SEND for Reading, is on screen and will be doing a short input on the developments we're looking to do. I'm going to look forward to the entertaining point where Roxana tries to put slides up and they will probably not work, but what would a public meeting be if it didn't work quite correctly? So there'll be some light humour there, I'm sure, as we watch the technical things to work. No pressure there, Roxana. As a very brief introduction, in 2021, we were lucky as an area in Reading to have an area SEND inspection, which demonstrated that we were doing a lot of things quite well. I think whenever we look at SEND nationally and locally, we can be pleased where we've identified areas where things are going well, but we cannot be complacent about the challenges that our families and our children are experiencing. Last year's update showed some of the strong progress that we have made, but the areas of further work that needs doing. And the update today, I think, follows board members in exactly that same vein. We've broken the paper down into each strand to give you a sense of granularity about the areas that we have all agreed as a partnership are important underneath each strand, the progress that we have made, and then some of the next steps that we need to make and secure. I would give it as an overall picture of assurance to board that we have made some strong progress in key areas. We are focusing, I think, on the things that matter the most. But we cannot afford to be complacent. And there are some really critical things that we would remind board about that we've talked about here before, but that we need to keep and maintain our focus on. The support for the most vulnerable of our children with the most complex needs further consideration and work. We've got an inclusive system, but for the most vulnerable children where care as well as independence needs to happen, it's an area of continued priority, including into adulthood. The sufficiency of provision so that every single child with an additional need is celebrated for their difference and not deficit, to make sure that we are absolutely there about the outcomes of a child from their perspective. We do not yet consistently achieve that, and our ambition, as we've said in our strategy, to be one of the best local authority areas for children with SEND demands that we achieve that. And the national mental health crisis for our young people has not gone away. Colleagues may read the paper and see, particularly, I think, one of the pleasing areas we've spent some time on regarding emotionally based school avoidance. We've made some really great impacts. We have still far too many children not able to access full-time education. We have far too many children not being able to fulfill their potential because of emotionally based school avoidance, mental health and wellbeing concerns. And access to mental health support, whilst I think it's an area that as a collective priority we can be pleased that we have both paid attention to it and we're making progress, not every child is receiving the support at the right place at the right time they need to, and we must deliver on that promise that we've set out in our strategy to every single child. At this point, I will just pass over to Sarah at the ICB for any additional points before I ask Reading Families Forum for any commentary they'd like to share.
There we go, first technical difficulties of the meeting. I'll take the hit on that one. So I'm Sarah, I'm the Exec Director for Berkshire West within our Integrated Care Board that covers Berkshire West, Oxfordshire and Buckinghamshire. Thank you very much, Brian. That was a really helpful overview of the paper, and I'm representing colleagues who've been doing a lot of the detailed work with Brian and the team. I think I'd just briefly reiterate our commitment to working on this in partnership, and it's the only way forward that we can go with these services. That's so important that we take an integrated approach. Noting the increase in demand and the increasing need amongst our children, we absolutely need to be doing all we can to be able to meet those needs. So we're doing specific pieces of work within the ICB, looking at the therapeutic input that we're providing from a healthcare perspective, and seeing how we can make sure that that is given as early as possible and in a real preventative way to avoid further escalation and get that support into our children as early as possible so that they benefit as soon as possible from it. And also making sure that we are taking learning from other parts of the system and other inspections and bringing that together so that we can all move forward together and take on board that wider learning. So that's all going to be feeding into the continuing programme of work that we're doing at the moment with colleagues in this area. And just again, a thank you for the really collaborative approach that we're taking on this at the moment.
Thank you, Sarah. A quick apology, Chair. Ramona at Reading Families Forum, our Chair, is also on screen. Apologies, Ramona, I didn't quite clock you there. I'll now hand over to Reading Families Forum colleagues for their contribution, because I must say, and I'll commend now, Reading Families Forum is a source of great strength for us within Reading. We have a strong partnership with families. Every year I worry about the asks that we put on families. We are talking about family representatives who have got significant caring responsibilities for some very vulnerable children. And every year I'm delighted to see the rejuvenation, the growth and the progress of our Families Forum. It's something that Reading we're very privileged to have as a function and as a stakeholder group. Now I've butted you up a bit, Ramona. I didn't know if you had any things you wanted to say on screen before I come back to colleagues in the room.
Hello everybody. So as Brian said, I'm Ramona Bridgman. I chair the Reading Families Forum. I'm a parent carer of myself to 2 young adults with SEND. I'd echo what you're saying, Brian, and we've actually just started surveying our families. We try and survey them every year. We've had 57 responses in the last week. And they identify lots of good things happening in Reading. I think if I could sum up their concerns in a couple of sentences, it would be difficulty getting that, accessing the right thing for their child at the right time. Over 30 of them had made a formal complaint in the last 3 years to try and get the services that they need. I mean, I'm sure Pauline and Claire, as you're there, can talk a little bit more about some of those kinds of things. So I think it is just making sure that we've got the right support in place. And I know Roxana's going to talk about a really positive project that Reading Families Forum are entirely behind, but I think it's just making sure that the service is responsive as well.
Thank you, Ramona. And on that basis, I'll hand over to colleagues for further comment here.
Pauline Hamilton, Reading Families Forum. Yeah, I just echo everything that Brian said. We are aware that the local authority is working in difficult conditions, but that doesn't stop us pushing, because, you know, at the end of the day, it's the children and families that count. And there are specific areas where there are difficulties. Provision for SEND is one of them, and hopefully Roxana's input will actually relieve that to some extent with more support in mainstream, which ultimately should or could mean that there's less demand for special, but not necessarily in all cases. There's a significant issue on transition at 18 and 19, 25, depending on the child's and the young adult's needs, particularly for the more complex cases, the cases that need 24/7 care, but still need stimulation and activity. I'm afraid Reading, there's a big black hole, and even in the surrounding areas which they try and access, demand far outstrips provision. And I know that Claire's got issues over children with mental health. She's also a member of another charity, or actually, are you the CEO?
I'm the only member of staff. I voluntarily run a local support group. I voluntarily run a support group called Fifi's Vision. We have no funding, but we have an open door policy for any additional needs of any age. We have seen an increase in school avoidance, whether that's emotional based or needs not being met. So we have now got, I dread to think how many families that are now attending because they're home ed. We're seeing mental health, they're being signposted to the wrong areas, or because they have an autism diagnosis, they are then left and told there's no provision for them. So, yeah, I think there is a big gaps, as you say, but there are good things, obviously, but at the moment, I'm overwhelmed with 525 families on my own, and that's growing. So.
Thank you. Claire, the reason why, and it might feel a bit sobering for board members to hear both the challenges as well as the opportunities, but I think one of the successes that we've had as an area is that this is a very honest area about how well we support our families, and that's why we've done so well. When we look at the national statistics and we look at the SEND strategy, our outcomes in terms of the attainment for our youngsters is good. We do better than we do for other disadvantaged groups for our youngsters with SEND in Reading, but we do that because we're very, very clear about where we need to improve. So I think to wrap up in terms of key areas of improvement that we've talked about, making sure that there's enough education provision for children with for those with those needs, that we've got the right mental health support and the right signposting, that we have good post-18 provision, and particularly that bit about care versus education, the idea about enablement as opposed to necessarily full independence, and ensuring that we're supporting every single child so that they're not invisible. These are themes that are in the paper, but hopefully board will feel and agree with me that it comes to life a bit more when you have got our key people in the room, our families that can speak to that lived experience. To conclude our introduction, Chair, I was going to hand over to Roxana, because the critical thing behind how we meet our challenges this year is something that Pauline and Claire have both spoken to. Actually, Ramona, you've referred to it as well. How do we get the right provision in place at the right time with the right support? And Roxana can talk a little bit about a very ambitious programme that we're very excited about that we're launching to hopefully take us to the next level. Roxana, over to you.
Thank you, Brian. I'm going to attempt to share my slides now. If it doesn't work, that's fine. I kind of designed them to have minimal language on them, just in case it didn't work sharing them. So I will endeavour to share them.
Working
Okay.
so far.
Is it working okay? Fantastic.
If you just put it onto slideshow, then it will be bigger. So
Yeah.
Brilliant.
Okay. So thank you again to both Brian and Reading Families Forum and colleagues from ICB for their introductions. I would like to introduce you to a new service that Reading will be launching. And this comes off the back of the work that we did with the Department for Education's Delivering Better Value project. But firstly, it's worth reminding colleagues what were our key sort of insights from the DBV project. Analysis of our 21-22 high needs block spending identified that the vast majority of our spend incurred within mainstream special schools, independent non-maintained special school provision, and mainstream schools. There's been a 34% growth in the number of EHC plans maintained in mainstream since 2020. And it's worth pausing to unpack that figure. That 34% growth is not only an increase in the number of plans per se, but also a proportionate increase in the number of plans maintained in the mainstream sector. Where does this place Reading against our statistical neighbours? Well, we have a higher number of EHCPs in the 2 to 18 population than our statistical neighbours, and a lower proportion of EHCPs in mainstream than our statistical neighbours. A key starting point for special school placements was around transition years, particularly reception, so children moving from preschool or nursery into reception. And again, at age 11, that was the key area, age 11, so transitioning from primary to secondary. Broken down by need, the most common primary need identified for those with an EHCP in maintained special schools or in mainstream was autism. And case review data revealed that it was felt that 31% of children with EHCPs could have been adequately supported without the need for an EHCP plan. Mainstream had the highest number of children who it was felt could be adequately supported in the absence of a plan, and that was at 40%. So what does need to be improved for our children with SEND to be better supported in mainstream? And let's remember that there are many advantages to having an EHCP, not least statutory protection, clear recognition of a child's needs, access to therapeutic input, and funding. There are disadvantages as well in terms of how long a child has to wait in order to get an EHCP, and then sometimes in reaching agreement about the delivery of that plan. So what could we do to better meet children's needs before an EHCP is needed? Well, the data showed that teachers did not feel currently sufficiently confident in supporting all children with SEND, particularly those with complex and high needs. Unsurprisingly and symmetrically, parents didn't feel confident that the mainstream sector could consistently meet the needs of their children with SEND, again, especially those with complex and high needs. Both teachers and parents felt that the availability of specialist support for children with things such as curriculum design was not adequate. It wasn't sufficiently available to them, and what was available didn't always match with their needs, as the needs profiles of our children with SEND has evolved in the last 5 to 10 years. Off the back of this learning from the DBV project, Reading was successful in applying for a £1 million grant to improve our local offer. We worked closely, and I'm very grateful for the input of colleagues both from Health and Reading Family Forum, to design an offer around what was found in the DBV analysis to better provide for children at what's called an ordinarily available level. So what can we do, in short, to better support children in mainstream who either don't have an EHCP or those with an EHCP, but who may be at risk of a placement breakdown? So I'd like to introduce you to the service that we are all genuinely very, very excited about. And it's going to be called RISE, Reading Inclusion Support in Education. And RISE will work to improve the quality of ordinarily available provision for all children in Reading. So what will it do to support schools? It will be led by a full-time senior educational psychologist to oversee and implement the improvement of Reading's ordinarily available provision and the graduated response. Ordinarily available provision, for colleagues who may not be aware, is what schools are able to provide in their universal offer to all children. And as I'm sure you can understand, that can sometimes be quite variable between schools, between primary and secondary stages. And what we want to do is to upskill all our teaching workforce, our teaching assistants across the Reading area, so that it doesn't matter where a child goes to school, they still get an excellent level of support for their particular area of need. Every school will have a named SEND consultant who will be able to offer free advice to their SENCO, conduct whole school SEND audits, and deliver training free at point of delivery, which is something that was very important to our teaching staff. They said they really wanted more teaching and input in how to support children with SEND, but sometimes it was prohibitively expensive for them to access that. We will also add 5 SEND specialists who will again be available free of charge to our schools and be able to provide specialist input relating to areas that schools and families identified they wanted more support with. This will include occupational therapy, speech and language, supporting specialist input for children with ASC, supporting children struggling, as a colleague has alluded to earlier, with emotionally based school avoidance, and specialist support for children struggling with emotional regulation. How will RISE support families and children? Co-production has to be at the heart of what we do. This service isn't for us. This service is for children, their families and schools. So we've advocated and we're successful in getting the funding to support a community engagement research officer who will ensure this co-production with all key stakeholders. They will work to co-produce the KPIs for RISE and also then to assess the impact against those KPIs as the project rolls on. To support that person, there will be a full-time data analyst who will be able to create and maintain a data dashboard to ensure honesty and transparency with all stakeholders regarding how the project is going. I realise that was a very brief whistle stop, so if there are any comments or questions, I'll be very willing to answer those.
Thanks, Roxana. Chair, that brings to an end the introduction, and we'd welcome questions from board.
Thank you to all speakers there. I think Councillor Gittings wanted to.
Yeah, thank you, Chair. I'm aware of the very long agenda, so I'll try and keep my comments quick. And I'm aware that probably I'm not on camera, which is probably as well for the members of the public. Yeah, I mean, I look. First of all, I really welcome the presentation on some of the positive things that we're trying to do in Reading, and also we have obviously recently adopted the autism strategy, and I think that's a really important document. I suppose I feel as though what the professionals involved, it seems to me that they're almost like the child in the Holland with the finger in the dike, trying to keep, because this is such an immense national problem, obviously focused on Reading as well, which is a service that is frankly been underfunded by the government, both through the education system and through the amount of funding that we receive in local government. So all the budgets are under immense pressure in all demand-led services, and I'm lead counsellor for adult social care, and I was particularly concerned to hear the numbers involved with people who are struggling from transition from being a child to being an adult, because that's obviously clearly a massive problem for those individuals, and they need proper support. And as a local authority, we'd obviously do our very best to do that. But at the same time, our resources are horribly stretched. So, as somebody said, this is pretty sobering, to be honest, this stuff. And I just briefly, and I suppose it's sort of my question is to probably maybe to Brian, but also to the lady making the presentation. And 3.57 on the report, CAM's capacity, crisis response and support for children with learning difficulties and autism remains a concern for parents and carers. I mean, I think that's a sort of massive understatement. I mean, the amount of I go into schools actually teaching something called bikeability as a sort of part of my day job, and I, without being any sort of expert in this field, I regularly see, sadly, children who probably do, but sometimes they volunteer it to me, so I'm waiting for a CAMS referral, but they could be waiting for years. And for schools tackling with this, it's good that we're getting 5 SEND officers and some specialist support, but this is an incredible problem, because these are undiagnosed children, let alone the people that already are. So the parents are facing incredibly long waits for this. So I'm just wondering what sort of progress can we make in that area, because I think probably the 30 people that made a complaint, many of that might be around waiting for referrals. And then once they've got the referral, for the sort of service that they're receiving. And I'm not trying to play a blame game here, but this is a very, very difficult area because of the funding. So it's a concern, I think, for councillors of all political parties, actually, whichever authority you're in. And it's a massive concern, obviously, for teachers. And one of the reasons that teachers are leaving the profession and there's a workforce crisis, I think, as I've heard in feedback from teachers, is that it's the pressures brought about by having to obviously sadly deal with this area with not a lot of support in schools from specialists. So that's welcome, but I think, as I said, I feel that we could obviously hope to do more.
Thank you, Councillor. So, excuse me, there's a couple of pieces to the response, really. I'll hand over to colleagues in the ICB regarding the commissioning of specialist CAMs, because I think that's where you've located it. But I would draw your attention, particularly on that one, to 3.48. So the Integrated Care Board has identified this as a particular area, and a learning disability CAMS approach is kind of being mobilised across Berkshire. So there's a particular piece of work that will need to progress quickly.
Yes, thank you.
I think the first bit, then, I would also say, in terms of what's happened so far, is we've invested as much as we possibly can as a council in supporting the emotional health and wellbeing of our young people, including specific monies were commissioned by this administration. No other local authority I can find that's done this. So this, I think, is a laudable commitment before my time, so hence I can be complimentary about it, to make sure that we had an emotionally based school advice support approach in place. Now, that was action that this council took following COVID, which was not nationally funded, but it was something that locally the council felt was important to do. And actually, Claire's lived experience, other families' lived experiences that Claire's organisation is supporting, absolutely emphasises we are there. I go back to my introduction. We are focusing on the right things, the resources that are needed to achieve the things we need to do. I think Councillor raises a really pertinent point on the resources. Before I hand over to colleagues, people will be aware of one of the reasons why the Delivering Better Value programme has been commissioned by the Department for Education is the National Association of Directors of Children's Services said that there was insufficient money within the system for children with SEND. Within the programme already, we have seen such examples as last November, Kent County Council receiving a £130 million grant to deal with the current deficit. I'll repeat that. That was £130 million to fill the hole in the current budget due to SEND needs. So the demand is rising. There is a need for us to mobilise every resource we have. And I think this board, the assurance you need to see is, are we focusing on the right things? I feel we are. B, are we deploying every resource that we have across the partnership? I didn't know, sir, if there was anything else you wanted to add on the Learning Disability CAM service, which I know is a priority that's being rolled out.
No, I think just to firstly repeat, that is absolutely a priority for the ICB and something that we do want to see improvements on. But if it was something easy, then we'd have done it a long time ago. I know you understand that. So what we might want to do is, as Brian mentioned, there's the board and the work that's going on at the moment, and perhaps at the next meeting we might want to have a focused look at the actions that are being taken there, specifically working with colleagues in Berkshire Healthcare as well, who I know are also having a really focused look at this, but are also plagued with workforce challenges and the availability of the right skills and some of the pathways that we need to review to make sure they are as flexible and kind of current as possible to make the best use of the skilled workforce that we do have now, looking outside of just your core traditional practitioners. So if we bring a future update, that might be helpful to go into the detail of that.
I would welcome that, actually. I think obviously that's the purpose of this board. Immense agenda aside, perhaps we need to have extra meetings, but wonderful.
Thank you. Thank you, Sarah. John, you had a question?
Yeah, John Ashton, Interim Director of Public Health for Reading and West Berkshire. I think this is an important area, Chair, where we don't really have a full picture. The focus we have at the moment is very much downstream, and we don't really have a rounded view on what's going on in terms of incidence and prevalence and why we're seeing an increase in demand, because this starts well before the local authority gets involved. It starts with antenatal and maternity services. There's a contribution here from birth trauma and the contribution of the NHS, whether it's the hospital and paediatrics or whether it's general practice. And we really need a joined up picture based on the intelligence of what's actually happening. Now, I've asked our analysts in public health to begin to do some work around this, but I'm not sure quite how quickly it's going to be possible to throw light on it. But I think we do need to join the dots between the NHS and local government and the other people who really have a part to play here, because in a sense the local authorities are picking up the tab for responsibilities that may lie elsewhere, and I think we need to have a proper rounded picture of this. So I'm just flagging that up really at this stage.
Thank you, John.
I think, John, you actually speak to another something that's very important, and I would remind board, therefore, there are some committed items on your work programme ahead that we need to pay mindful attention to. The Joint Strategic Needs Assessment, we've been doing them for a long time. It can feel like that diet plan we start in January that doesn't feel like it's going to achieve the outcomes we want, and it's just a must do. The Joint Strategic Needs Assessment is our shared evidence base by which we can prioritise our decision making, that we can make investments through our integrated care system, that we can align all of our understanding and learning. The fact that we've got that public health led opportunity to refresh our joint strategic needs assessment so our evidence base is so secure feels a really important thing for Health and Wellbeing Board that I would plea as Director of Education, but also in terms of the co-chair of this SEND work for us to focus on. We have got some other bits of join up as well that John encourages me to remind us about. So the fact that we secured quite an ambitious, jointly agreed between health partners, schools, co-produced with Reading families, involving the voices of children and young people. Our area SEND strategy in 2022 set a really good benchmark. The reason we can be this sober is because we have a good plan. We check this every year. We come here and make sure that we are focusing on the right things. It is the right way of us working together, and that integration is serving us well in Reading. And the fact that we have work strands that are co-led by health and local authority together in a sustained, embedded way over a long period of time, that is something that will help us achieve what we need to achieve. The delivery, I think the opportunity that we have with the integrated care system as it becomes online for us to further drive improvements, as Councillor mentioned in comments and remarks earlier, I think we've got really clear opportunities in the next year that we must take. We cannot afford not to take those opportunities in the next year.
Thank you, Brian. Did we have anybody else? Any questions on this? Okay, I'd firstly really like to thank colleagues from the Reading Families Forum for attending today and, talking about your experiences. I think it's really important for us to hear. And I'm so sorry, I didn't catch your name. Claire, okay, so we'll get your details for the minutes. And obviously you raised some concerns, which I'm sure Brian will pick up and we could talk about separately. So I think it's really important to hear firsthand the experiences. I mean, so many issues have been raised here, and I welcome the report, but there is, a lot of concerns around emotionally school avoidance and the reasons and the causes. We'd all like more funding. It's positive to see collaborative working, so it's something that can come back to the board. So thank you very much for everybody for your comments on that. Thank you. So we're moving on to agenda item 6, which is the Health and Wellbeing Strategy Quarterly Implementation Plan Narrative and Dashboard Report, which is to be presented by Amanda. Amanda there?
Thank you,
yes, Amanda's online. Thanks, Amanda.
Thank you, Chair. So just to clarify, today there won't be an update on the dashboard. It's focused on the narrative update in terms of the progress of our local implementation plans. So in terms of, before I start, I'm Amanda Nyeke. I'm the Public Health and Wellbeing Manager for Reading Borough Council. So in terms of our progress to date, a lot of the actions that are included in our implementation plans are progressing extremely well. There is some strong collaborative work taking place across Reading with our partners. Our focus is very much to ensure that the strategy and the implementation plans and the actions within them continue to be fit for purpose. So I'll just provide a very quick overview of some of the key highlights from each priority area. With regards to priority area 1, this is led by the Reading Integration Board, and there's quite a significant piece of work that's due to take place or due to be launched this month in October, and this is the Community Wellness Outreach Project. This is a project that is a collaboration to build on existing community-based services, to enable direct referrals or drop-in options for people in order for them to be able to receive the full NHS health check. However, one of the big strengths of this project is that they will be able to receive additional wellbeing support. So that may be financial advice, mental health awareness, referrals to community and voluntary sector services, and further signposting. The goal is that it will be a holistic program that offers support and offers to prevent avoidable illnesses, and as well as to address inequalities with regards to some of those people that may not necessarily be able to access our GP services. So that's a bit of a summary on one of the key projects being delivered as part of our reducing the differences in health between different groups of people. With regards to priority 2, this priority continues to be led by the Reading Integration Board and is a very similar priority in terms of working towards addressing some of these inequalities. The focus is around supporting individuals that are at high risk of bad health outcomes to live healthier lives. So the Reading Integration Board currently is working with our voluntary sector partners, including supporting to do work that will look at supporting people with learning disabilities and a range of other health needs. We're working with a system which is called the Joy app, and some of you may have heard of this. This app is currently funded through the Better Care Fund and is a pilot project that Reading Voluntary Action are leading on. This app is brilliant. It's used as part of the social prescribing platform. It enables GPs to directly refer to community and voluntary sector services in order to make sure that people's well-being is supported. So it offers up that holistic whole round approach as well. Regarding our priority 3 from our strategy, this priority focuses on helping children and families in earlier settings, and this is led by the Under 5s work stream of the One Reading Partnership. So again, their actions within their implementation plans are progressing really well. There are universal and targeted services that were developed, that continue to be developed, and continue to be delivered collaboratively with partners across the system. There's focus around provision of pre-birth support by antenatal groups. There's support including promotion of the importance of preschool boosters. This has been a recent priority due to some of the take-up initially dropping. So vaccinations are being given in earlier childhood when children are most vulnerable to disease. A couple of other areas of progress include the Welcome Speech and Language tool. This has been piloted and reviewed by the Best Start for Speech, Language and Communication Multi-Agency Working Group. At present, 45% of the children that have had the review have made progress, so that's really positive. So just moving us along to priority 4. So priority 4 and 5 of the strategy focus on mental health. And I think, as we could hear from previous conversation, this is quite a significant area. It is a key priority across Reading, as well as our local authority neighbours. Priority 4 itself focuses on the mental health of children and young people. And this is led by the One Reading Partnership and SEND Strategy Group. Again, pretty much the bulk of the 7 priority areas are progressing really well. There is the school attendance and mental health focus, which looks at the impact of current mental health services on school attendance. There is positive impact on the emotionally based school avoidance team, and the goal is looking at strategies to ensure that this valuable work continues. There is a focus on inequalities in mental health in relation to those children and young people from global majority heritage. There is a task and finish group, which is ensuring that this work continues to progress. This is the Reading Anti-Racist and Equality Forum. And the goal here, again, is to build on the work by the Public Health Adults Mental Health Working Group. There is also another focus on the addressing inequalities in relation to mental health for children and young people who are neurodiverse. There's a lot of work happening in terms of reviewing the evidence base, ensuring that interventions that are being planned and delivered are aligning with the evidence base, but also making sure that they align with the needs of the local population, because it's one thing to look at the evidence, but also to ensure that, you know, it aligns with the needs of the local people. So at present, we now have a specialist camp service for children in care across Berkshire West, and this has been co-commissioned. So I haven't gone through all the elements of Priority 4, but just pulled out some of the key highlights there. And then last but not least is Priority 5, which focuses on the mental health of all adults. This is being delivered and led by the Mental Wellbeing Group. This group consists of partners from across Reading, all with different focuses and perspectives in terms of how to address mental health for adults and how to support our residents. A bit of work took place some months ago, which looked at delivering an interactive workshop for us to be able, in Reading, to be able to do a self-assessment process for the Prevention Concordat for better mental health. So this work continues to be under development. We've also started work around the local suicide prevention action plan, and there is a multi-agency group with partners from across the system, again, once working together. So there's a lot of collaborative working taking place across all the priority areas and all the individual actions. There is a new mental health support program that launched recently in Reading, the Managing Emotions program, and this support individuals who struggle to manage their emotions and support those caring for them. So as you can see, I've just tried to pull out some of the key elements, but if you've had the opportunity to read the full report, there's much more detail and much more context around some of these key areas. So I'm happy to take any questions. Thank you.
Thank you, Amanda. Do we have any questions from colleagues? No, I can't see anyone. No, thank you. It's oh, apologies, John Ashton. Have you got your hand up there, John?
Sorry, that's an old hand.
Oh,
thank you.
Okay. I can't see anybody else. Yeah, thank you, Amanda. It's a really informative report, very interesting read actually, and I actually really like the layout as well. It's all very readable. I was just going to ask about a couple of the amber ratings in the, I think priority 4, and there was one in priority 5. So priority 5, which was the let's have a look. It's focused targeted support on groups at greater risk. I don't know if you could just quickly expand on that one.
Sure. So let's have a look here. Focusing on support.
Yeah, the amber rating in the focused targeted support on groups at greater risk.
So this is the Pan Berkshire Suicide Prevention Group work and the strategy work that's taking place. We are actually in the process of going through finalizing this, which is why it's amber, because we make sure that anything that's green is fully up and running. So there's still a lot of work in terms of working across Reading, working with partners to ensure that the Pan Berkshire strategy is reflecting what is relevant for both for Wokingham, West Berkshire and Reading. So as a group, there have been some key groups identified that we want to work with. But again, as I said, at this stage, we haven't reached a point where we can say that everything is fully up and running and functional. So there are quite a few pressures and quite a few dependencies in terms of what will enable us to complete this, but it's definitely underway. So I would say it's not an area of concern. We are currently just in the process of getting this up and running.
Thank
And
you.
then-
That's really helpful. Thank you, Amanda. Oh, sorry. Are you coming?
I was just going to highlight the final amber there around the mental health needs assessment. It's a very similar situation whereby we're in the process of completing it, and we should have the final mental health needs assessment complete before the end of the year. And then we can mark that green.
Oh, that's really useful to know that. Thank you, Amanda. And Martin, do you have a question?
Thanks, Chair. I was just going to add a few more details to what Amanda's just very helpfully provided about the suicide prevention work. This is a very important priority for us. It comes under priority area 5. I lead on that for the health and wellbeing strategy. And to give everybody on the board a brief update, we have an interim consultant in public health, Mike Bridges, who's leading on a pan-Berkshire suicide prevention strategy. That's necessary because we've got a national strategy, a new national strategy that's just come out, but we need a strategy that addresses the complexity of the public health system in Berkshire. The focus will be on each local authority having an action plan, which is focused on effective preventative action. And we've got one in Reading that's been led by myself and Deb Hunter. We've met 4 times. We've reviewed the 2019 action plan. So we'll have one for 2023. And in fact, earlier on today, I was having a very helpful discussion with colleagues in safeguarding, and the plan increases to engage stakeholders and partners so that we can focus on those priority groups that Amanda was just talking about. So this is some movement at last on suicide prevention for Reading.
That's really positive. Thank you, Martin. Thanks for that update. Do any other colleagues want to raise any points or questions? No. Okay, well, thank you very much for this report, Amanda. Thank you.
Thank you, Chair. Take care.
So are we happy to approve this report? Yep. Thank you. So we're moving on now to agenda item 7, which is the Better Care Fund integration update and plan for 2023-25. And we have Bev Nicholson presenting.
Thank you. Thanks very much. This is a very quick overview of the, you'll be pleased to know, because there are multiple papers in the pack. I apologise for that. And it's a bumper pack this time because we had end of year planning and planning for 23-25 all in one go. So I apologise for the size of the pack, but this hopefully will summarise everything nicely for everybody. So we'll start with the Better Care Fund end of year return for 22-23. All 4 national conditions were met alongside the fortnightly reporting deadlines that we had for the Adult Social Care Discharge Fund. There was a final underspend at end of year of 788k, which was as a result of some funding that was being transferred back to the council from commissioned services that weren't running in that period, and some delays in project starts alongside additional government funding that we received. It was quite late in the year, it was ring-fenced for specific activities, which meant the money that we had actually allocated against that those activities, we then had to use the ring-fenced funding. So what we did was allocate that underspend from last year to projects in this year that help us meet the Better Care Fund objectives and the metrics for 23-25. The Better Care Fund planning template for this year. This is very high level overview. So this year, the plan was for a 2-year period. So you'll see from here, we've got income from year 1 and year 2 and expenditure year 1 and 2 planned. It expanded over that period to help us in terms of forward planning and working with our commission services. The Section 75 framework agreement between the council and the Integrated Care Board is to be in place by the 31st of October, and our draft has already been submitted. So we're hoping to be able to meet that deadline. What's missing from this total amount was the additional disabled facilities grant funding that was received just recently of 104k, but that will be included in the future quarterly returns, and the outlines from them will come back to the Health and Wellbeing Board for the first return in January. Just a quick overview there of the national conditions that we have to meet in terms of and the planning requirements. We received confirmation on the 18th of September that our submitted Better Care Fund plan has met the national conditions and the planning requirements, and that our plan has been approved. The Better Care Fund metrics that we have, the targets and the performance for Q1 23-24. We've met all of them. And for those of you that are regulars at the Health and Wellbeing Board, you'll know that the 91-day target, the last one on that list, is usually a really challenging one for us, and we often do miss that one, but we've had some significant improvements in that area, which is really positive. The number of older adults whose long-term care needs are met by admission to residential or nursing care, I just want to flag here because our projection to year end at the moment is a flat line projection based on activity so far this year. And it says 506 and our target is no more than 433. However, I've looked back over the data over the last 3 years, and our admissions to permanent long-term care on average in those last 5 months are only 38% of the total for the year. So we do expect it to be a reduction over those latter months. So hopefully we will be able to still maintain our performance on target. And then just a little bit about the discharge fund. It was formerly called the Adult Social Care Discharge Fund, but this is a separate portion of the Better Care Fund that dedicated ring-fenced for discharge, hospital discharge, and creating additional capacity in the market to manage that demand. The fund was released to us this year for the whole of the year, and you will see that our expenditure to date, based on the return that was submitted on the 18th of September, was 25% of the ICB portion of funding and 9% of the local authority proportion of funding. That's because we have backloaded, I don't know if that's the right word, our expenditure, our planned expenditure towards the end of the year, where we tend to get the highest demand for discharge and for helping people come out of hospital as quickly as possible. So there are plans in place to increase capacity in the market over that period of time from November onwards. So you will start to see a marked increase in expenditure over that period. We do expect to spend it all. We did last year, and it created additional capacity both in staffing and in market support for people coming out of hospital. So that's my presentation. So thank you very much. Are there any questions? Apologies, I didn't introduce myself, Chair. I'm Bev Nicholson, the Integration Programme Manager for Reading. Thank you.
Thank you very much, Bev. Thank you. Councillor Gittings?
Yeah, wasn't much question as to, as actually to congratulate the team on a series of greens on the chart, particularly the obviously the thing, hospital discharge, number of people going to care homes. I mean, it's clearly in people's advantageous for people to be able to stay in their home. The council's got a home first policy. It's not for everybody home first. Some people obviously do need to be admitted to care homes, and if for obvious reasons. But longer people can stay in their homes, all the better. And it seems to be moving in the positive direction. That's not to say that these figures might suddenly move into amber at some point. But I've just taken over as the council adult social care, and I must say I find this a really heartening report. So thanks very much for the work that you've done.
Thank you.
Thank you, Councillor Gittings. I'd also like to thank colleagues for that report. It was a really welcome report, very detailed. Great to see the progress and the performance. I was just going to ask about how prepared we are going into winter and your thoughts on that, if you could update the board.
Yes, thank you, Councillor McEwen. We are prepared. I mean, our commissioning team have been working very hard on making sure that we've got additional capacity available in home care hours and social work capacity to manage discharges coming out of hospital over the winter period. The most challenging ones tend to be our pathway 3 discharges, where they tend to be very, very complex care needs. So that's where we're really focusing our attentions, alongside training up home care, domiciliary care staff in reablement focused training. So that gives us a bit more capacity in the market, so that when somebody's coming out of hospital, actually they're not just waiting for a reablement package. They might just need a low level of reablement, and therefore our home care, our domiciliary care partners can help with that. So that's where we're focusing some of that funding to support us in that.
Thank you, that's really helpful. I can't see any other questions or comments. No hands up. Nobody have missed. Okay. Well, thank you very much for that report. Thank you. We are all happy to note the report. Thank you. So if we move on now to agenda item 8, and we have it's Right Care, Right Person, a presentation by Emma Garside. Oh yes, Emma's online. Thank you. Welcome, Emma.
Good afternoon, everybody. Thank you, and thank you, Nikki, for displaying the presentation. My name is Emma Garside. I'm a Chief Superintendent with Thames Valley Police. I've got responsibility for policing in Oxfordshire, but in addition to that, I'm the police lead for the implementation of Right Care, Right Person, which is an initiative I'm going to share with you this afternoon. So on to the next slide, please. So I'll start with a little bit of context as to what Right Care, Right Person is, and then as I take you through the presentation, we'll move into a more localised look at what is going on here across the Thames Valley. It is something you may have heard about in national media, and that is because this is a national initiative. This isn't just something which is unique to Thames Valley. And in July of this year, a national partnership agreement was actually signed between the National Police Chiefs Council, the Home Office, Department of Health and Social Care and NHS England, committing all of our agencies to work together to deliver Right Care, Right Person. And in essence, what this approach is all about is being sure that someone at a time of need has the most appropriate response from the agency who is most appropriate to help. Historically, the police have been very involved in these type of calls. However, police officers aren't routinely trained or necessarily in most betterly skilled, and some people actually feel stigmatised or criminalised by the police involvement in mental health cases. So this is all about looking at who is the right person to respond and putting at the heart of this the person who may be at that time in need of some specialist help. Next slide, please. So this is something which started initially in Humberside area back in 2019 and was deemed by all of the agencies involved in Humberside to be very effective and was picked up as good practice. And it's on the back of the work in Humberside that this approach is now being rolled out, as I say, nationally. The College of Policing, which is a professional body that all police forces link in with, have developed toolkits for policing, and within NHS England and other agencies, their own sort of toolkits and information are being put together as we speak. Really important to remember that this isn't about demand reduction for the police, and this is about ensuring that the police are used to attend incidents that only the police can attend and deal with, and free up our capacity to do that, whilst recognising that other people may be better placed to deal with some of these calls. Next one, Nikki, please. So in terms of some principles, a really important message I want you to take away this afternoon is that this isn't the police stepping away from anything to do with mental health. And actually in this force, hopefully I can reassure you that that's quite the contrary. So where there is a clear policing purpose, an immediate threat to life, threat of serious injury, we will obviously be the most appropriate agency to attend, and we absolutely will still be attending all of these jobs. Clearly, there will be occasions where there are legal responsibilities which require us to use, powers that we have that other agencies don't have. We've had concerns from people sort of saying, well, I'm concerned my staff are vulnerable or they're being threatened. If somebody is, if their crime has occurred or a crime is about to occur, we will absolutely still be attending these calls. And in Thames Valley Police, we've recently invested in creating 10 dedicated mental health police officer posts. And that is, hopefully testament to our demonstrating that we are very involved in this work and not stepping away from it. I think some of the national media headlines that focused on the way that this is being rolled out in other police forces have perhaps given people the idea that this is the police stepping away. When we need to be there, we absolutely will be still responding. Next slide, thank you. I won't go into this in too much detail. You can read it in your packs, but it will give you a flavour that the right care, right person approach there's different sections to it. And you can read the detail of those in your own time. And we have currently in this area in Thames Valley gone live with just 3 of those phases. And I'll talk a little bit more about the ones we've gone live with in a moment, but that's just for your information of the type of sort of business that this incorporates. Next one, please. So in Thames Valley, we are an early evaluation force alongside Cambridgeshire Police and Cheshire Police. And what that means is that we've got some additional support from the Home Office in terms of evaluating our progress. So there's some additional support and help with an evaluation, and that shared learning, learning from what we've done, and those other 2 forces will help other police forces across the country as they roll this out. Our Chief Constable signed off our approach in April this year, and we have been embarking on a phased rollout since May. Internally, there's an operational group that I lead and reference again to the 10 specialist mental health officers who will be involved in this work, but lots of other work linked with mental health as well. We are still recruiting for the posts to cover West Berkshire. The jobs have been advertised, and at the moment we haven't had any applicants. So I just mentioned that, giving you this is the Reading board, obviously. There's fortnightly meetings where all police forces join in together to hear what's going on from a national perspective. And the good news is that the sort of approach that we've taken in Thames Valley has been commended, and other forces are looking to us to see what we have been doing. The College of Policing, which is that abbreviation COP, they've released already 3 toolkits to support the forces, as can be seen there, SRO being Senior Responsible Officer Guidance, and we await the publication of 3 further toolkits to help us with the ongoing rollout. And as I said, within other agencies, their professional bodies are also in the process of creating such documents to help staff with the rollout of this initiative. The Contact Management Centre, that's our department where anyone who's ringing the police, the calls will go into. The staff there are probably the staff who are most impacted by this change, and they have received training and have introduced a toolkit which is helping them when they're deciding on who is the best resource to deploy to a particular job. And that is under continuous review and is a live toolkit based on feedback from partners. Sort of in our early stages, we have had some feedback where people were concerned that the police made the decision not to go, and we were able to kind of review all of those calls and see, were it the right decision, or actually should we have gone? So that feedback from partners has proven to be really useful in developing the toolkit in contact management. Next one, please. So as I mentioned, there's different phases to right care, right person, and it was intentional that we decided to take a phased approach recognising that there's an awful lot of work to be done here, and that being better than trying to sort of take on too much in those early stages. So we're live with the concern for safety calls, sometimes known as welfare checks, absent without leave reports from psychiatric hospitals, and then walk out from healthcare settings that more often than not is an A&E type setting, but doesn't exclusively only apply to A&E. So the 3 areas below are the ones we have not yet started. We haven't got a start date set as to when work in that area will begin. And that is largely because this will be a partnership decision, not something that the police will decide. And clearly there's a lot of work to be done to be sure that everybody is joined up and ready before we take on any more. Important point to note at the bottom, at this stage in Thames Valley, we're not applying the right care, right person approach to under 18-year-olds. Nationally, the guidance doesn't distinguish between child and adult. But as part of our phased approach, we felt we wanted to just focus on our approach to calls involving adults, and then perhaps in time revisit whether we wish to roll this out further. We do recognise, of course, that even in dealing with an adult, if there are perhaps children in the home, that there could be an impact. So that is obviously part of our consideration and risk assessment as well. Next one, Nikki, thank you. So a little bit of a sort of a screenshot here of the toolkit that our call takers will be using in the call centres when the calls are coming in. This is, as I say, sort of a screenshot of something which is a live interactive document, and this just really guides them as to what may be the most appropriate response. Is it a police officer going immediately, or do we need to be signposting that call to someone else? Clearly, the more information that people can give us at the time of the call, that is, the advice we're giving people. We can only, make our decisions based on the information that's given. So the more thorough that can be, the more detailed, that really helps us inform the risk assessment that we're making. It's not the case that anyone has to ring up and mention right care, right person. Any individual will just ring us, report whatever it is they feel they need to be reporting to the police, and we will work through this toolkit ourselves. Next one, thank you, Nikki. There's been lots of strategic engagement. I mean, I think it's fair to say back in April, when I first came into this portfolio of work, there were some concerns that people hadn't heard and didn't feel well enough cited on what the right care, right person approach was. As I say, it's not uniquely a police initiative, but we have kind of driven this in getting it sort of off the ground in these early months and bringing together all of our key partners to get this up and running across the Thames Valley as we have done. And I shan't read out a long list of names, but that just gives you a flavour of the different groups of people that we've been engaging with and what level. And our sort of chief constable has been, liaising at his level with chief executive partners and directors of adult social care, by way of example, too. So this is sort of right the way through from his level, right the way down to sort of practitioner level. We're trying to reach out, and part of the reason I'm grateful for your time this afternoon to be part of another group of people who've been briefed. And the final slide, Nikki, please. So next steps. A strategic management board is in the process of being set up. That will have oversight across the whole of Thames Valley and be jointly chaired by one of our senior officers and NHS England, again just reflecting the fact that this is a joint agency response to this initiative. Locally, across the counties and Milton Keynes, sort of local implementation teams, multi-agency teams are being set up. And I'm pleased to say the chair of the Berkshire group was identified this week, and the Berkshire implementation team will be having their first meeting, I'm sure, within the next month. And that is where that local impact can be assessed. Any kind of issues, any worries on the strands that we're live with will be tracked. I believe there's a role for the adult safeguarding boards in sort of having that assurance given into them in each of the different parts of Thames Valley. around what is going on across the areas in terms of any risk and safeguarding concerns. And these local implementation teams are sort of, as I say, setting up and will be driving that activity to local level, feeding then into that strategic management board, which is due to meet for the first time in November. Feedback loop is really, really important. As I say, we have gone live. We are encouraging feedback, good, bad or indifferent, on any decisions that we've made that people may feel were the wrong decision, or actually feedback also where we've got it right. And local LPA commanders, so many of you will know Steve Raffield, he's your commander for Reading. Clearly all my commanders have a role in briefing their own partners and hopefully allaying any fears about this sort of slight change to our approach. And then in time we'll have the Home Office evaluation that they've been working with us on, which hopefully will provide useful learning for the future too. So it's very much work in progress, but I just thought it relevant to share with you where we were at this point, and hopefully allay any fears that this certainly isn't the police stepping away and relinquishing our responsibilities with these type of calls either. Thank you, Chair.
Thank you very much. Just before Councillor Gittings, I've just got a quick question myself. Again, thank you very much for the presentation. Obviously a lot of information, and I was going to ask really about how you're going to monitor the impact of Right Care, Right Place. You did cover a lot of that, but I'm just wondering sort of if you can expand on it a little bit, and also will the policy be reviewed if there's any if there's further concerns raised? I was curious as well, you've talked about the strategic partners that you engage with, but I'd just like to know a little bit more about sort of community groups that you've engaged with. So I think that's incredibly important, because I know a lot of people weren't particularly aware of the change in policy. And just on a positive note, it's good to hear about the mental health officers. I think you mentioned there were 10 of them. And will any of the mental health officers cover Reading, or will it be shared roles? So sorry, I know that's a few questions there, but
yeah, I'll try my best to remember all of those. So I guess in terms of the impact of decisions and collating that information, I mean, that is where the feedback loop is really, really important, and we have put in place an escalation policy. Of course, the call will come in, we will make a decision on deployment, and actually that may be the end of it. If we go, it's unlikely that anyone will come back to us and raise a concern. If we don't go and we don't hear anything more, one could assume that were the right decision. If we are having information come back into us, and this is being documented and collated on our side, in terms of people feeling that we made the wrong decision, that is, the information we are collating. The latest data set I looked at, we are still attending about 60% of these calls that come in. And so, I think feedback, from partners to date has been that the impact hasn't been as great as some people feared it may be. But, again, we are early days of this. In terms of communication more widely, there has been sort of, media communication on the approach. So there is information out there. In terms of specific engagement with community groups, that's not something that the police have led on per se. And I guess it is important to stress that this isn't, just a police initiative, and the responsibility sits with us all to push these messages out. And I think it's a real balance in the messages that we're giving, because clearly we don't want to put people off calling. If someone thinks they need the help from the police, they must still ring. And actually, if it's not for us, we can signpost elsewhere. I think you asked a question around in terms of the policy being reviewed. Yes, it's constantly under review. What we've implemented in Thames Valley has mirrored very closely the Humberside approach. Our approach is quite different to that of the Metropolitan Police, which has been reported on quite heavily in the media. We are following the best practice suggested by Humberside, and that is the approach which the College of Policing are recommending forces do adopt from a policing perspective. So we are in line with that, with the exception we haven't gone live with children as of yet. Other forces have. Sorry, Chair, were there any other questions?
I think the other one from me was to do with the mental health officers. Will it cover Reading or will it be a shared role?
Oh yes, sorry. There's 10 across the force. There will be 2 that work in the West Berkshire area.
Berkshire West.
Two people.
Okay, thank you. Thank you. Councillor Gittings.
Yeah, sorry. Thanks very much, Joan. You've actually asked some of the questions I was going to ask, particularly about the deployment in Reading. And naturally, as Lead Council for Adult Social Care, this is obviously an area that did concern us, particularly when it was first flagged up. And I think it is fair to say that it was rather sprung on local authorities and the health service. I'm not blaming you particularly. It's obviously you've made strides to improve that, but there was a lot of concern about it. I mean, I'll just make a couple of observations. It appears, I mean, in my other one of my other roles, I'm on the fire authority, and we obviously have a fantastic Thames Valley Fire Control where calls are screened and decide who and when is deployed. It appears to me that a lot of responsibility in this area, an enormous amount of responsibility, is around your call handling system, because you're the people taking the calls and have got to respond. So it concerns me in a way, but I suppose in a way, if the people have the right training, then that may deal with that, because people are going to call in an emergency, and sometimes they may not even be the best to assess that. I just also wanted to read out sort of when this is something from the chairman of the local government community and health and wellbeing called chap called David Fothergill. He said he welcomes this because police may not be the most appropriate service to respond, and I think we all want police time freed up to tackle some of the issues that local residents talk to us about all the time as councillors. It says, however, we are concerned this is being rolled out too quickly with inadequate local engagement and partnership working, meaning that other agencies risk being unable to pick up any increase in demand for their services. I just wonder if that really is still the case. I mean, the chair mentioned about talking to community groups, but it does slightly concern me that this is being introduced, it's gone live, and there's a lack of local knowledge about this around, and also a bit of a lack of coordination between partnerships between local councils and the health service. So you can see where I'm getting at. There's some concerns.
Yeah, no, definitely. I'll just respond to those points. I mean, I think you're right in terms of, when the Chief Constable made the decision to go live back in April, we have reflected on the fact that the stakeholder engagement that had been done up until that point wasn't as thorough as it could have been. There'd been a lot of engagement with mental health partners, but actually adult social care partners and other sort of health partners that weren't necessarily in the mental health side of things hadn't had the updates that they could have done from us. And I think also what hasn't helped is within policing, we have had a very good sort of information flow from national policing teams to local forces. And as I say, I go to a fortnightly meeting where all police forces come together. There have been similar things set up by NHS England, and for whatever reason, it's not for me to comment. It would seem that some of that sort of cascading of information within other agencies internally hasn't been as effective as perhaps everyone would have wished either. So you are right to say that back in April there were those concerns raised. An awful amount of work has been done since to try and correct that and put the messages out. And I'm much more confident now that we have the local implementation team set up. There's one, as I say, setting up for Berkshire with very good representation across, all of the key partners who are in any way impacted, fire service, SCAS, other emergency blue light partners as well. That working together will be much better. And so, yeah, now that those groups are in place, we can take stock, look at what the impact's been, look at any learning, and that's where I say that the remaining phases that are yet to go live, that will be a collective decision by that strategic management group as to when that is done. And there's no rush to start. It's very clear from the Home Office that it's not, this all has to be in by a certain date or anything of that kind. And the fact we're a Home Office evaluation force isn't about us going any more quickly or rushing things through. We were just sort of identified because of our relationship with the Home Office and progress that had been made that they thought others could learn from. Some of our mistakes, making sure people don't do those.
Well, I was just about to sort of say, I mean, obviously about the call handling. Sadly, in these cases, it only needs one very high-profile case, and we've seen some examples of that where it's gone wrong. The police haven't came out, and somebody's been endangered to kind of undermine the whole of this. So it's a difficult area, isn't it?
Yeah, and the call handlers are the staff who have had that extensive training. The advice to every other officer is if you're told to deploy to a job, you're going and you go as usual. But it's the call handlers, as you say, that have had that additional training.
Thank you, Emma, and thank you for your question, Councillor Gittings. I think John has a question.
Yes, thanks, Chair. Well, I share the concerns that have been expressed by others here this afternoon. I mean, I think, Emma, that the way you've responded to some of the questions isn't very reassuring, because when you talk about cascading of information and putting the messages out, this all reinforces the idea that this has been decided by the police, and then they're setting about corralling everybody to fall in behind them. So it feels very top down. And I think the concerns really have to be a couple of things, really. One of them is that the police work is not black and white. Police work overlaps with social work and with health work and so on. And very much it's a question of people being able to be first responders and to deal with what they come across in their work in the first instance, and until perhaps more appropriate help is available. And we've seen that with many of the fire and rescue services that have actually trained their officers up to be health first responders. I mean, I've spent the last 30 plus years in conversation with chief constables trying to strengthen the training of new constables in health, in mental health and so on. And I don't think we can still be assured that that's what's happening when you're recruiting new folk into the police force. If it's common experience that if you have particular people who are it for something, then everybody else will think it's nothing to do with them. So if you have 10 officers across West Berkshire or the territory we're talking about who are labelled as mental health police officers, then this really takes the pressure off every other officer from actually being literate in dealing with health issues, and particularly mental health issues. So I think we need to reserve judgment about this, and we need to monitor it very closely to see what the impact is. And as we said in a meeting I was in with you earlier in the week, we need to have now some measures that are made explicit and on the table for how we'll know whether this is working or not. I don't think it does to say we'll come up with the measures later. I think we need the measures now to know what we're going to be looking at to see if this is okay.
Thank you, John, and I guess some observations from you and some questions. I guess just picking up on the mental health dedicated officers, they are in addition to anything else that the force already has and will continue to do. People still have inputs on mental health during training. These are additional officers recognising the complexity of the work in this area and where specialist knowledge can be really helpful. So they are in addition to. and they do have a slightly different role to that of, you know, a sort of response officer with a more general understanding. And we saw this as a really positive investment of, you know, officers into this space. You know, so that's sort of one observation. They, you know, there are posts still to be recruited into. That those in post have been filled since April. So again, you know, keeping under review the impact they are making is important. In terms of it being felt like this has been, you know, pushed on to others, you know, that has been acknowledged, and that was part of the apology that I referenced to the previous person who spoke, you know, by our chief officer, that the police did push the button on this. You know, we have been trying to readdress the balance of some of the calls that come into policing for some time. And you know, we did make that decision to go live, and that decision won't be unpicked. You know, collectively, I haven't come across many people, if any people, who disagree with this type of approach and cannot see the benefits in a more joined up approach, making better use collectively across agencies of a number of different resources. So I think the approach people completely understand and actually want the police to be free to deal with other matters that the police are best trained to deal with. But you're right in terms of it feeling, you know, a surprise or others being forced into things. But now with the arrangements that are in place, that is what is being tracked and monitored. And interestingly, out of the Oxfordshire meeting, which was earlier this week, collectively, you know, yes, there have been some impact, but not to the extent that some people were concerned about, because we're still going to quite a lot of these calls.
Yeah, my final quick point is that it's interesting that you should take a cut-off of 18 years, because again, that illustrates a lack of joining up with what's going on elsewhere, because nowadays we regard adolescence as extending beyond 18 into the 20s, if not further, actually. So that, you know, there's a lack of coherence to joining up the agenda with the way other agencies are now framing what young people are and what adolescence is.
Thank you, John. Thank you. Melissa had a question.
Thank you, Chair. And thank you, Emma. My name is Melissa Wise. I'm the Exec Director for Communities and Adult Social Care here at Reading. Really appreciate your honest presentation and that real attempt to kind of demystify some of the myth and the intention around the policy. I think you're probably gathering, as expected, some real concern across partners about that point you've made about demand shift. And I guess as partners, we're naturally quite nervous about any impact this might have. So I suspect you're feeling some of that tension. Some colleagues have already referenced some of my questions, but just 3 points really. I think it'd be really helpful if you could circulate how partners can feed in. So you've talked about that feedback loop for specific cases. I'm not sure I'm aware of what that is. Others might, but I think there'd be some real merit in you circulating that. You talked about, obviously this is Thames Valley wide, so you talked about some strategic and implementation groups, and I guess I'm sat here in Reading saying, how can I ensure that we are represented? So I'd like some thoughts on that. And then my final reflection, I think in terms of learning the lessons and the acknowledgement, Emma, that you've had about, you know, the build up to this, it'd be really good to get your thoughts on how you're going to ensure that partners are updated on an ongoing basis on the implementation of the new elements as planned and the impact, because as you've said, Emma, today, you know, 60% of these calls are still being attended, and that again cuts through some of that concern and tension. So I think an ongoing loop for that's really important. Thank you.
Yeah, no, I don't disagree with anything that you've said, and that is exactly what these local groups will be tracking and communicating back into their respective agencies and more widely. I can certainly circulate for your notes that, you know, if people are concerned about decisions we've made, what they need to do either at the time of the call or if they want to give it to us for a retrospective look.
Thank you. Alice has a question.
Hi, hello Emma. Can you hear me?
Yes,
Yeah.
thank you.
Yeah. Hi, I'm Alice Clifton. I'm the lead officer for Health Watch Reading. One of the things that we deal with is the public's voice, and it feels like very top down. So I do think there is an element that you need to have a consultation with the public, because they are the ones who will have the impact too. So what are your plans for that as such? Because I do think that that needs this to happen for them to come on board as well.
I mean, I think it's important to remember that nationally, this has been signed off as an approach across the country that will be taken. This isn't something which is unique to this area. And, I completely accept the implementation needs to be joined up with partners, the impact on those affected, of course. And I think the communication with the public, we have to be really careful not to frighten people or put people off ringing. And in some ways, we want to sort of encourage people, if they feel they need help, to still ring. And whether it's the police that help them or someone else, we will, endeavour as we do now to be sure that the right person responds. So I do agree in terms of, anyone impacted, we want to capture that. But I think it's a real balance. We don't want to frighten people or have people sort of be unnecessarily worried that, there won't be someone there to help them, because if it's not the police, it's likely to be someone else. But no, I take your point around that voice being heard.
Yeah, but the thing is, they're already frightened now because there's already so many things have changed. So I do think that, you need to reassure the community better by communicating properly. I do say that it is worrying.
Okay, thank you.
Thank you for your question there, Alice. Do we have any further questions or comments? Okay, well, thank you very much for attending today, Emma, online. But, it's an important update. I do think it'll be important for you to come back to the board at some point. So it's something we can discuss and arrange.
Yeah,
okay, so thank you very much.
Thank you.
So if we move on then to agenda item 9, inequalities and prevention, reducing premature preventable mortality project. And Sarah is presenting, Sarah Webster.
Brilliant. Thank you very much, Chair. And Amanda gave quite a helpful overview of this in the summary that she gave a moment ago. But I'm very excited about this project, so I'm going to talk a little bit about it again and then open up for any questions. So in a nutshell, the Integrated Care Board, the organisation I work for, ring-fenced a level of funding that was allocated to us here in the Berkshire West patch, with colleagues in Wokingham and West Berkshire, as well as here in Reading. To invest in services with quite a large remit for us to determine our own fates, really, with this, but with the aim being to really take a preventative approach, so to help our population improve their health and well-being in a preventative manner, and also target those areas that are most at need, where we know we've got inequalities of access and outcomes to our services at the moment. So across the patch, we all came together to put our heads together to think about how to best spend this money, which totals 2.6 million over 2 years. And rather than going through a kind of an individual bid process, I really wanted this to be a collaborative co-design process with as minimum as possible bureaucracy around it to maximise the impact of the service we designed. So we, through looking at a level of evidence and data around what drives our largest areas of preventable ill health, we know that the data tells us that cardiovascular disease and cardiovascular related illness is a huge contributor to preventable early mortality and the impact that has on an individual's healthy life years as well, and some of the data is outlined in the paper. So we wanted to do something around that, around how could we take some action to reduce the prevalence of cardiovascular related illness. But we wanted to do more than that as well. So we also wanted to consider some of the wider things that are impacting on people's health and well-being in our communities. So we landed on a proposal that's outlined in the paper around a community wellness outreach service. So this is building on the NHS health check, but taking a kind of enhanced health check out into the communities most at need. So we've developed kind of a core offering that's going to be consistent across the 3 borough areas of this kind of enhanced health check. And then there was an ask of our Reading Integration Board and counterparts in Wokingham and West Berkshire to localise that. So with that in mind, what's really going to make a difference for the residents of Reading, and what other services might want to go out with that health check to provide the help that's needed? For example, we know there might be some areas that would benefit from financial advice as well, or some tailored mental health support services, or just signposting into other services that are there. And then really importantly, once we've had that initial sort of health check conversation, how do we then follow up on that? So it's not just a single intervention, a single kind of drop in, or the different arrangements I'll come on to in a moment, and then that's it. So we've built that into the model as well, in terms of really clear links back into general practice where necessary, but also kind of follow-up conversations, and then links into other health and wellbeing services. So that's where, so we've had lots of conversations through the Reading Integration Board, which is a subgroup of this committee and includes partners from all of our respective organisations across the patch. And the model that's outlined at a high level around what the service might look like is outlined in the paper. It's looking like the way of getting that out into the communities will be building on the Meet Pete service that I know we've had updates on at this committee in the past. And this is a service, an outreach service that Royal Berkshire have developed, which is taking kind of a step in this direction, and really successfully in taking health services out into communities. And the way of reaching the people that we think will benefit most from the service is going to be twofold. Firstly, we'll be able to use our shared data on people's health needs that's in our what's called connected care, to identify those residents that we think would most benefit from this sort of proactive preventative service, and invite them into clinics to have these conversations. But we know that doesn't always reach everybody. Some people, for various reasons, don't always respond when they're invited to services for very good reasons often. And so we wanted to make sure there's also the opportunity to build this service into trusted community sites, cafes, libraries, other hubs where people are already going. So we can have a drop-in element as well, and opportunistically capture some of those people and have conversations delivered by people who are trusted in the community as well. So it's not always going to be a doctor or a nurse dropping into a cafe and as a stranger, really. Actually, we want to work with community champions that are already well established in the communities, provide a standard level of training. That we're developing a training programme with the University of Reading at the moment, so another partner in the system, and really get this going. So really excited about this. And then there's also an element of the funding that's going to be used for evaluation and looking at the impact that this is having on our communities, hopefully a positive impact, and also considering then how we can build on our kind of integrated information that we've got and the intelligence between all of our organisations, so that we can continue to take these preventative services out, so that hopefully when we look back in 10 or 15 years time, we'll be thinking, oh, thank goodness we did that, because now people are healthier, people are happier, and look at the impact this has had on our residents of Reading, and where do we go from this? So at the moment it's a 18-month to 2-year pilot, and looking to launch later this month, I believe. I'm looking to Bev, who's been a driving force behind some of the detail on this as well, working with colleagues in Royal Berks and wider, and also a huge thank you to colleagues in general practice. Andy personally has been very closely involved in this, along with other primary care colleagues, to really get behind the detail. So a really good example of partnership working, and we'll be able to continue to report back on the impact that this has as it rolls out.
Thank you, Sarah. Do we have any questions or comments from colleagues? I can't see anybody online. No, I really welcome this report and the collaborative working, and just, the impact the positive impact it will have on health of our residents. It'll be interesting to get the, when you return in a few months or 18 months, and the positive work, and get feedback on the positive work that we carried out.
Thank you.
So thank you.
I also should have said a huge thank you to public health colleagues as well, who've been instrumental in this. I probably should name every single person, because there's been an awful lot of work that's gone into it, and I'm a fear of missing people out. But yeah, no, really excited about this.
an example of good collaborative working.
Absolutely.
So yeah, that's very positive. Thank you very much for that. So are we happy to note the report? Yes, and so we'll move on then to agenda item 10, which is access to maternity services. And we have Christine Harding here to
Hello.
present. Thank you, Christine.
Thank you. So my name's Christine Harding and I'm the Director of Midwifery at the Royal Berks Hospital. And I'm here, thank you for inviting me to talk in response to a couple of reports that I believe have been presented here. So that's the Health Watch Survey 2022 and also the Community Participatory, I can't say that word, Action Report. And to talk about some of the things that are going on in maternity within the Royal Berks. So some of the themes that came out of those reports were around mental health, around birth trauma, around antenatal continuity of carer, not feeling listened to, the cost and availability of antenatal and postnatal classes, staff shortages and language barriers. So I'm hoping I'll be able to give you some information to cover some of that. So the first thing I wanted to talk about on the next slide, thank you, is around the continuity of carer. So we know there's lots of evidence that talks about the positive impact for women and birthing people regarding the continuity of the person providing the care all the way through their pregnancy journey. We've got two full continuity teams at the Royal Berks. One of them is a home birth team that supports women who are planning home birth, and the other one is our Blossom team. This is a team who work in the community in a geographical area of vulnerability and social deprivation. So we're really focusing our continuity, our full continuity package in those areas. We've also got the Poppy team, who are a team of midwives who care for women with defined vulnerabilities. They provide continuity antenatally and postnatally. At the moment, they don't look after women during labour, but that is something that we are hoping to move forward with. In terms of other initiatives we've got to support the vulnerable populations, our Poppy team have started the Seeking Sanctuary Clinic, which you may or may not be aware of. So this is a clinic that is led by the Poppy team, but actually it's multi-professional and multi-agency, and they support women and birthing people who are refugees or have been subject to trafficking or are asylum seekers. And we've had some really good feedback on the level of support. And we have partners within general practice, within public health, within health visiting, who support that work as well. In terms of the next steps for continuity, what I would like to do next really is to focus on our antenatal and postnatal continuity. So that is making sure that women during their pregnancy and after the birth are seeing the same midwife. We know that doing the whole package, including the labour as well, is a lot more challenging because of the models of care that requires. So to focus on the antenatal and postnatal will enable us to see some benefit. So that's the next step with continuity. If we move on to the next slide, in terms of staffing, we've had some really good focused work around midwifery staffing in particular over the last 12-18 months. We've seen our turnover rate drop from just over 19% to 9% in the last 12 months, which is really positive. We have got a vacancy rate within midwifery at the hospital. It's currently sitting at about 15%. But we've actually got names against the majority of those vacant posts that we have. We're just waiting for them to come into position and be able to be supported and orientated. Some of those are internationally educated midwives, so we've done really well with our recruitment in that way, with support from and funding from Health Education England. So we are looking in a very positive position with our midwifery recruitment. The equality, diversity and inclusion work is a massive work stream and impacts on every aspect of maternity care. We've recently appointed a new EDI lead midwife, funded through the organisation, through the trust. Now, I'm very conscious that it isn't just one person's role. We have rolled out mandatory training for all of our midwives during the course of the year for EDI, which has been really well received. But the focus of our inclusion midwife is to really lead the work that we are doing, developing work streams to link in with partners, and to work with the wider organisation as well. One of the things that we've started doing quite successfully is we look at ethnicity and diversity alongside all of our outcomes within maternity care. And that means that we're starting to really be able to drill down to look at the outcomes for different groups and then be able to work out and work together to work out how we can improve things. So that's a good piece of work that we are doing at the moment. If we move on to the next slide, one of the examples of some of the work in this space is around what we've done is we have used the equality delivery system, which is a tool to be able to evidence what we're doing in two key areas. One of the key areas is around the percentage of women from diverse groups booking within 10 weeks of their pregnancy being confirmed. And that's really a good proxy measure for women being able to access antenatal screening, which is very important. And the other one is around postnatal support following discharge. So we have benchmarked ourselves using the equality delivery system tool into how we are progressing with those two key themes. And we held an event in September last month where we invited various stakeholders and service users and partners. We presented the evidence and they were able to benchmark us and evaluate. And the result of that is that we will have a good action plan to really help steer where we need to improve and move forward with that. If we move on to the next slide. In terms of, so if we move on to the next slide. Oh, sorry, my mistake. In terms of any more additional next steps, I've already talked about the continuity of care wanting to improve antenatal. Another important aspect that you've mentioned is around women not feeling listened to. One of the things that we have developed in partnership with the wider Bob local maternity and neonatal system is the new personalised care and support plan, which is a tool that all women will be carrying and will help them to understand their journey through maternity services and also to identify what's important specifically to them. And that will be able to frame conversations and care and information exchange throughout their journey. So that's something that we are rolling out in the next few weeks. The cost and availability of maternity classes was another aspect. So we relaunched our antenatal and infant feeding classes very recently. We provide these in partnership with the NCT. There is no cost for first-time mums or for mums who have had a significant gap since their last pregnancy. We work very closely with the NCT because we're very, very keen to understand the uptake, to understand the diversity of women and families uptaking that education. And obviously we work very closely with them around the content. So we receive regular reports, we have regular meetings with them to understand that data and see what we can do to make sure that this is available and that women can access it. We've also got a very well established easy English education class for women for whom English isn't their first language, and that's been very well evaluated. In terms of maternal mental health support, we obviously have a referral pathway into perinatal mental health, and that is a pathway that anybody within the organisation can refer women to. We ask at our booking appointments and at all of our antenatal and postnatal appointments about women's mental health, about the history of mental health, and around their general feelings of well-being. We also have a birth reflection service, which is the service where women and their partners can be referred to after they've given birth to their baby, or they can self-refer, and there's no time scale on that, so they can refer themselves or be referred at any time to come back to meet with a senior midwife and to talk through their birth experience. And we use a tool during that, the triage for that appointment, to help us identify anybody who has got significant birth trauma, PTSD, for instance, and we then use that as a tool to refer them on to birth trauma services. We've also got a perinatal mental health clinic, which is multi-professional. At the moment, it is run by midwife, an obstetrician, a perinatal mental health worker, and we're very, very keen to have a health visitor come and get involved in that. That would be the next step for that clinic. We've also got a senior midwife who's undertaking an advanced clinical practitioner role, who's specifically focusing on mental health for women who might be low to moderate mental health, with the aim to provide support, signposting, so that we can help to prevent this from escalating into more significant mental health. RUPI, on the next slide, is our perinatal equity befriender. This is a new role that we brought into the organisation. RUPI is also employed as a chaplain within the organisation, and she works with us and works with the families within maternity and in the community, really to support birthing partners and their partners, birthing people and their partners around their experiences and their needs, specific vulnerabilities. She will also visit them in the community and support them in the community as appropriate. And she spends quite a bit of time on the postnatal wards talking to families. One of the things I'm really excited that she's helping us with is to improve the feedback that we get from women who don't necessarily have English as their first language. Therefore, the traditional methods of getting feedback from them via our friends and family survey, or logging on, to do a survey that might be a bit off-putting. She will take that information to them and actually collate some feedback directly for us. So I'm really looking forward to being able to receive that. Next steps in terms of the perinatal mental health. I've already mentioned some of those. The personalised support plan will help. We do a lot of signposting to other organisations and other partners, and we can do a lot more to make sure that we have got all that information and that the midwives have got that at their fingertips. I've already explained about the clinic that we want to improve and include health visiting, and the role of the advanced clinical practitioner, which will be very helpful and very important to support the midwives in the service. Thank you.
Thank you very much, Christine. Just quickly, I'm sure colleagues will have some questions. I just want to say thank you for the report. I appreciate your efforts to address the lots of questions that were raised here at the board previously, and I was going to ask you how you will ensure continuous improvement as well.
Yeah, absolutely. I mean, it's something that we are very passionate about. We have lots of mechanisms around the metrics that we monitor and the performance that we monitor and how that is fed in within the wider organisation and up to the exec board as well. So as I've said, a lot of the themes around the equity, diversity and our outcomes are naturally fed into all of those things that we report higher up through the organisation. So it's not something that we're just working on in isolation from anything else.
Thank you. Thanks, Christine. And I think Alice was first, the question.
Hi, Christine. Just to find out from you, as much as you share it with us, how do you share it with the public about this? Because a lot of this is not, women are saying they're not listened to. I think improving the communication will make much better for their experience. So how are you sharing this with the public? Because, like all this, I sort of shared some of the stuff that you've had. I've asked the questions to some of the communities and they know nothing about this.
Yeah. You're absolutely right, Alice, and it is a really difficult task to reach all groups. We obviously work very closely with the Maternity and Neonatal Voices Partnership. We have spent quite a lot of time reaching out to various different groups and getting their confidence and getting their trust. We now need to start using some of those relationships that we have got and we have developed in specific groups to ask them now to give us their feedback and their opinions and work with us a bit more closely. So it is something that is a very big task that we need to do. We have various strategies for feeding back to women and feeding back to groups. But we really want to hear from them and get their opinions. That's just as important for us.
But we get that. We get that feedback. And that's the one thing what would be nice for maternity to engage with us, because
Yeah.
we hear this a lot. And, even the CPA report itself, women are saying that they are not listened to. There was a conference last March that women were sharing about their experience. So I do think there's a lot of work that needs to be, but you reach out. The maternity voices are not the only people out there. There are others as well. So it will be nice to have a collaboration as well with people like I'm part of a public voice. So,
Yeah.
there is, but women are saying this because we've just come out from an event in Acre, and women are saying they have not been heard at all. They have shared and they've not been heard.
Okay, thank you, Alice. I think the equity delivery system was a really good example, and we did have representation there from Healthwatch. It would have been nice to have a lot more representation there, but we know that this works. So it is possible to keep doing those events, but we're happy to work alongside any organisation that will help us reach women. We're very passionate about doing that, so I'd welcome your support to do that, Alice. Thank you.
Thank you, Alice. I'm just double checking. Is it John next?
Thanks.
For a question?
Thanks, Chair. So, Christine, thanks. I mean, it's good to be reassured about midwife staffing, but it's also good to hear you say you've got metrics. So, I mean, we could do with knowing what the numbers of vacancies are in the midwifery workforce and the turnover and the sickness absence.
Yeah.
Because, you know, major story on last night's Channel 4 News was the poor state of morale in maternity around the country. So we really need to, you know, have something more tangible about morale, because we know that that's, you know, underpins when things begin to go wrong. And the other part of that is when we have these scandals in maternity units, usually there's a poor relationship between the medical consultants and the midwives. So we need to know really what the state of play is in the hospital maternity unit between the doctors and the midwives, because these are the early signs. These are the canaries in the coal mine of a service which may be getting into trouble. So, you know, we could do with some crunchy kind of data about that. And similarly, you know, numbers of unplanned hysterectomies and stillbirths, you know, these are the endpoints, and the complaints to the hospital and the litigation that's in train, what court cases are in train for what kind of amounts of money at the moment because of things having gone wrong. These are the hard endpoints of the service. So the report you've given is very comforting about process, but I think we need the outcome measures on the table as well. If you can help with that, I think we'd appreciate it. Thanks.
Thank you, John. Did you want to come back? Sorry, Christine.
Yeah, yes, absolutely. So we have all of that data. We report that data through our clinical dashboard, which goes up to the execs, and we also report it out to the LM&S, so the local maternity and neonatal system, which is part of the ICB. So we are very transparent with that information. It's very interesting. Our maternity survey last year, and we're obviously just doing a new maternity survey now, but the maternity survey that we published from last year's data, maternity was rated as great, and that's the first time it's been rated as great for the last 3 years. So we definitely got some really positive culture within the workforce. Obviously, I can sit here and say that midwives and obstetricians work very closely together, and there are lots of examples of that. But I appreciate I haven't presented that actual data to you today, so thank you.
No, I think the Board of Health and Wellbeing should have access to that kind of data as well, you know, as well as the other committees you mentioned.
Yes, okay, thank you.
Thank you, John. I've got Andrew Statham.
Christine's covered quite a lot of this, but for the committee's benefit, I'm Andy Statham. I'm Director of Strategy at the Royal Berks. You know, I want to comment on how much time Christine and her team spend informing our board and our quality committee, and you know how much we, you know, how much focus and attention we're spending on that, much of which we put into the public debate, much of which we put into the public arena through our public boards. So, you know, we comment on that in our integrated performance report, which I'll come on to a bit later in the agenda. But you know, the amount of time and attention that our board and our non-executives spend on this agenda is really important because of these issues. I'm sure that Katie, who's our new chief nurse in the room and with you, will absolutely be focusing her time and attention on that as well.
Thank you, Andy. We've got a question from Martin.
Yeah, thank you, Chair. I'm Martin White, consultant in public health from Reading Borough Council. Thanks for that report, Christine. I can't overstate how important it is to us all. You know, this is the front end of prevention and the journey of prevention through the life course, isn't it? And I heard you very loud and clearly when you describing how you're grappling with that problem, which is probably being grappled with across the NHS and public services, about cultural competence and how do we get the feedback, and the really vital importance of how do those young mums to be feel, and how do the people working in the system feel, and how do they communicate across cultural barriers, professional boundaries, and all the rest of it. And I just wanted to kind of build on what Alice was saying earlier on, which I think helps very to frame it as well, is that it seems to me that there may be an opportunity there for public health and health promotion type support. We do commission health visitors. You're talking about some great ideas that have yet to be implemented. I'm sure the board are as interested as I am to find out what the findings will be, certainly about the use of the personalised care and support plan and Rupi's work as well. So yes, if there's any way in which we can support you and help you, then please do reach out.
Brilliant. Thank you very much.
Thank you, Martin. I think, I'm not sure who was next. I think Rachel was next. I think.
Yeah, Rachel Spencer. I'm the Chief Officer of Reading Voluntary Action, and I just wanted to thank you for the approach that you're taking. I'm aware of the many voluntary groups that you have been working with, and it's big. There's hundreds of communities out there, but I think you're absolutely taking the right approach by doing the outreach, going out into communities. You've responded to some of the issues that have been raised. There's quite a diverse offer that you've walked us through in your presentation, some of which will be effective and some of them won't. And that's absolutely fine. And I really welcome the approach that you're taking and look forward to seeing the outcomes from it. So.
Thank you, Rachel. And Andy?
Thank you. Hi, Andy Chersky, I'm a GP, and with my GP hat on, thank you for the report. I mean, it's very helpful to see all the initiatives to support women, both antenatally, postnatally, and dealing with sometimes the traumas of birth as well. Just to highlight from a GP perspective that all antenatal services are now covered by midwives. GPs do not do it anymore. Berkshire West was the last in the country apparently to hand over all antenatal care to midwives as of just over a year ago. So I just want to highlight that, and also just to thank you for all the hard work that the maternity services are doing to do that. And I know we're still in a little bit of a transition phase of building up the service to take on all the responsibilities of antenatal care, and just at some point a report on how that's gone and how the midwives are managing to do the full shebang of what antenatal care takes, and what's been taken away from GPs and how much you're doing it much better than us. Thank you.
Thank you.
Thank you, Andy. Do we have any other speakers or questions? Thank you very much for attending today. It's really useful to hear, and thanks for addressing, previous concerns. I do agree with colleagues that it would be very useful for you to come back at some point. Okay, so thank you very much. Right, so moving on then, so it's agenda item 11, Building Berkshire Together update, and we've got Alison Foster. It's online.
Yeah, hi everyone. Hi. Hi everyone. Have you got my presentation, or should I bring it up? I don't know how you work it. Which is easier for you guys?
I think Nikki's going to do that for you. Yeah.
Okay, thank you. Great, thank you. So just context for those who may not be aware, and just to bring us all on the same page. We know that in October 19, the Royal Berks was placed on the new hospital programme in cohort 4. And this means that we are full adopters of the new approach to building hospitals. And that was what the new hospital programme is about. It's about a new way of building hospitals. And this is going to be called Hospital 2.0. So, for example, it means standardised designs, centralised processes, modern methods of construction. And all of that is supposed to deliver through a programmatic approach, doing things once and sharing it, is to deliver economies of scale and reductions in the time and cost to build new healthcare facilities. So that's the purpose of the new hospital programme, and we are in cohort 4 of that. Next slide. So you will know that in May there was an announcement that funding had been secured for the new hospital programme up to 2030. So although it's a total envelope of 20 billion, 3.7 billion had already been allocated and is what has been used between the launch of the programme and this year. The rest of that money is to be spent between 2025 and 2030. So it's for that comprehensive spending review cycle. We also heard that there were 5 hospitals added to the programme who have RAC, so that's the reinforced autoclave area to concrete. Just to confirm, the Royal Berks does not have RAC, so we have had surveys done in the past and we don't have RAC. Sorry, there's a typo there, I just noticed. It should be RAAC. So what does this mean in terms of the number of hospitals that can be built before 2030 in that envelope? Some hospitals currently on the scheme will not be able to deliver before 2030, and that will be due to constraints on both the funding allocation, so there's now more hospitals for the same envelope, but also on things like supply chain issues. So if we all went out to the market and tried to procure or purchase all the things that we needed to do to build hospitals, the market wouldn't be ready for us all to be able to do that. There are other constraints, so that there are now that the programme's been given the go-ahead to proceed. In the time frame, there are hospitals out there who may need a new site, who may need to get planning permission. Once they start building, there might be issues that arise from that. So it's a moving feast, I guess, is what I'm saying. And in our case, we've been carrying out some just to confirm that the scheduling of the Royal Berks has not been decided. In fact, the scheduling, apart from the RAC hospitals, all the other hospitals are going through a process with the new hospital programme at the moment to understand when they can be scheduled, and they're assessing that based on their current circumstances this year. Are they ready to go to construction? Do they have planning issues? Do they need extra infrastructure? And for us, we are carrying out significant geotechnical surveys across the site to understand its suitability for a significant development on the site using Hospital 2.0. And this is a crucial decision as to where we will be scheduled. So I think if we go to the next slide. So what we're also doing, because we have options that, again, aren't fully decided because we have to understand the condition of our site to build. We are looking as well at other sites that we've identified through a site search. So we're looking at a greenfield site and a brownfield site, and early due diligence of those areas. But we are also working with and have met with the planners at Reading Borough Council and to explore the options in the borough around other alternative sites. So although our initial site search didn't identify any within the criteria, the council may be aware of land, for example, that wouldn't necessarily be out commercially. So we want to make sure that we've exhausted all avenues in terms of the Reading Borough Council area. So we are working with the council planners on that. Next slide. So there is a business case process with the release of any money that we get. We have done our strategic case, which is setting out our case for change, and that has been submitted a couple of years ago. That will need to be refreshed, but we have been progressing our outline business case, which is the significant part of the work, and that looks at all of the different options that are on the table and does some significant analysis to try and gather the evidence for any decision that's made. So that evidence plus consultation and engagement with the local community is what will drive what that decision will be, and it has to meet whatever the envelope is that we have been allocated. So I'm just sort of giving you an indication of where we are in that business case process. Next slide. So I guess just to summarise, the funding, not only is our position on where we're being scheduled isn't decided, but the funding envelope has also not been decided. There's been an initial allocation given to all of the sites on the programme, and that's still being worked through as to is that allocation going to be the right allocation for Hospital 2.0. So if I remind you that means that it's single rooms, for example, bigger spaces, fully digitally enabled, needs to be built using modern methods of construction, which means building it off-site and bringing it on-site. Those are the things that the funding is to fund, and we have to say, right, if this is the size that we need. Is that funding allocation right for that? So there's a lot of been submitting of information to the new hospital programme, lots of discussions with them that are taking place, and they are submitting an updated programme business case to the Treasury by March. But that does mean that actually between December and March, it goes through a lot of governance, as you guys will be aware of. It will need to go to NHS England, the new hospital programme, Department of Health and Social Care, ministerial approval process before it actually gets signed off at Treasury. So there's quite a lengthy governance process around how much the fund each individual sites will be getting and what their scheduling will be. Where our options will take us is heavily hinged at the moment on the delivery of the geotechnical surveys, and the full report for that is not due until April 24, although we are getting phased reports to give us an indication earlier than that. We won't really be able to make any final decisions until that's delivered in April. I think that was it. I think there's just another couple of slides on engagement. So I guess this is just to say that we are constantly going out and talking to and getting feedback from various different groups. You may remember we reported doing a survey, and the outcome of that survey last year with the local community that had over 3,500 responses. What we did notice was those responses weren't as diverse or reflective of the population that we serve. So we're doing our engagement this year is really focused and targeted at groups that weren't represented in that survey sample. So you'll see us in lots of different events, hopefully. We do have a big calendar of events on our website, so please just have a look on there and see where we might be. We are also open to invitations, so we have done lots of patient groups or civic society events, so a real range, so that we can get out to as many people as possible to ask them to be involved in the development of the hospital. And it may not be that there's something immediate that people might want to get involved in, but as we move forward and as the stages develop, if you're on our network and we're engaged with you and talking with you, that's the best way to get involved. We also have patient leaders at most of our meetings and involved in our work, and if people want to do something like that, then please do contact us. And next slide. So our next steps is to work with the new hospital programme over the next 5 months to finalise our scheme. We are doing a lot of work on our clinical model. So our hospital, which we're looking at potentially 8 to 10 years before it is developed, needs to be something that is right for our local population. And there's a huge amount of work across the Berkshire West system, in particular around what does out of hospital care look like? How close to home can we get it for people, and have services that don't necessarily all have to be centralised in one place, where people have said to us it's difficult to get to, difficult to park. I've not gone through a presentation without mentioning parking, but every presentation that I go to, parking always comes up, and access comes up. So there's a lot of work around how we use and engage digital to support that, how we work much more closely with primary care and community services locally to really look at how we can deliver services differently over the coming years, and then have a hospital that fits that new model. So the geo surveys are in progress. We have work on our data centre, so we are moving our data centre, which is in the centre of the site. So no matter where we go, what we do, that will have to be moved. And we are looking at options and working with local businesses actually to look at what the options for that is. We're very, very lucky in Reading. We are in Tech Valley, and have a lot of expertise around us. So we are engaging with some local businesses on some of that. We are continuing to look at options development. So I talked about what are the options for us off-site, and we're looking at some sites and working with Reading Borough Council, and there's an appraisal process to go with that. So we will be gathering the evidence about the suitability of those sites and those options. And as I said, engagement is extremely important to us, and that is a constant effort that we are trying to do, and in getting out to communities and getting them to work with us on this, because it's your hospital, and we want to make sure that, you know, at every stage there's an opportunity for people to become involved in it. And that's it, I think. Any questions?
Thank you very much, Alison. Do we have any questions from colleagues? Can I see any hands up? Oh, I can see a hand up and I can't see. Oh, it's John. Thank you, John.
So, thanks. I mean, there's no money. So the question is, have we got plans B, C, D and E? Because after the general election, I can't see capital programs going ahead. So, you know, what's the option appraisal tell us?
Not quite sure how to answer that. So we we are working anyway. To be honest with you, the work that I signalled and talked about happening across Berkshire West is a transformation piece that needs to happen anyway outside of hospital. So there's lots of work going on around what can we deliver in different places and deliver differently. So that's the first thing. And because the hospital, even if we had money now, it wouldn't happen for another few years. We have been told that we are getting funded for a new hospital, so I can only go by what we have been told. A new government, if there was a new government, we also have been told, of course, they're going to pause to review, but they don't anticipate that being very long, because they know that this is a much needed programme. And I guess what people are telling us across parties is that they feel that building new hospitals and new healthcare is important to every party. And I don't know, I can't predict what people are going to do, but that's how we're working at the moment. Is we're cracking on that we have an allocation coming. We are working with the new hospital programme and what that is, but we are also working on transforming services in the local community, regardless of a new hospital coming.
I think that's probably the right approach. I mean, none of us has a crystal ball, and HS2 was going to be built until Tuesday or Wednesday. And, we know that what we've really got to do is build strong primary care and community care. And that's where we need the proposals to be, ready to take off the shelf, because I imagine there's a change of government will really want to invest quite heavily in that side, and not particularly in hospitals again. But, as you say, my crystal ball may be no better than yours.
Okay, 100% agree with you. Yeah.
Thank you, John. Alice had a question.
Hi, Alison. Thank you.
Hi.
Where are your gaps of engagement, if you had any? Is there anywhere that you feel that they haven't engaged with you?
Yes, so we've got gaps in BAME communities. We've got gaps in some gaps with people who have learning disabilities, autism. So we're reaching out to those, and also men. So in terms of the survey, quite a lot of women fill out surveys. So that's a particular approach, a survey. And also younger people. So we have quite an older population completing it. It arguably is an older population who use the services most. So, they benefit most, but actually we're building a hospital for the future. and we could do with more young people to be engaged.
Thank you, Alice. And we've got Sarah who's got a question.
Thank you. I was just going to build on Alison's point in response to John's question around kind of what if funding doesn't come through. And as Alison said, we're using this as an opportunity to look at what the blueprint should be for services and move where that involves moving more into the community or general practice or wider primary care. That's really important. But then also considering what actions could we take now so that in 10 years' time, the activity flow that's currently going through parts of the acute wouldn't happen at all because we prevented it as well. So I just wanted to give some assurance around we want to build a more preventative lens into this work as well, which might influence the size and shape of the new hospital that's ultimately built, but will influence the way we deliver services regardless.
Thank you, Sarah. Do we have any other questions or comments? No, I can't see. So thank you very much, Alison. And
Thank you.
It's really beneficial. I know you've been to the board before to update the board about the work, and I appreciate, I'm sure we all appreciate the challenges, budgetary and timings, and there's so much uncertainty. So thank you very much. I just had a thought the other day. I wonder if we could open up to board members to have a look around the hospital. I know members of ACE were invited, that's Adults and Children's Services Committee, and it was really beneficial actually to see firsthand some of the challenges. So maybe it's something we could open up to board members as well.
Yes, please.
Yeah. Okay. Just a thought, maybe it's something we could send out to members. Thank you very much. Thank you for your time today.
Thank you.
Okay, thank
Bye.
you. Bye. Right then, we're moving on then. It's agenda item 12, and we've got the Royal Berkshire NHS Foundation Trust Integrated Performance Report, and Andy Statham is presenting online. Hi there, Andy.
Hi, thank you, Chair. So in your packs, you'll have seen the July data report, which was presented to our board at the end of August. This is actually a summary of a longer report that's available on our website and is available every month, which includes another 100+ metrics that we look at every month as part of our quality assurance work. But I'll do a quick summary of that now. So obviously July was a period of sustained challenge that's continued on into August for our services. That being driven by the needs of our local residents, catch up from the COVID position, and the prolonged period of industrial action that we've experienced in the NHS, particularly over the course of this financial year amongst junior doctors and doctors. As you'll see on the front page of the summary of the report, that led to 800 cancellations alone in the month of July. It's really important that despite that period of challenge, our headline and underlying metrics show that the team have been working really hard to maintain the quality of the services we're offering, and our quality metrics remain really strong. We're also celebrating a reduction in our staff turnover to below pre-pandemic levels. Recognising the hard work of our people directorate, and particularly actually of Christine and her team, and the work that's been going on in maternity, where we've had a sustained substantive reduction in the turnover of colleagues in that service. We're also recognising the relative performance of many of our services, particularly elective services, which whilst waits are very long, remain some of the lowest waits in the country, thanks to the work that our teams have been engaged in. We do, though, have particular challenges that we draw our board's attention to. Really important to draw members of this board to. That those relate to diagnostic services, where the capacity challenges, particularly through the industrial action, have compounded the high rates of demand that we're experiencing through those services, and our waits in those areas continue to be beyond what we we would want them to be, and as you'll see in the report, are rising. The demand impact of demand for urgent care through ED is a second area of challenge. And then the third area of challenge is relating to our financial plan, where the costs of industrial action are pretty much equivalent to the gap between our forecast plan and our actual realised position at the moment. If we look forward, I think it's really important. I note that we've already started in this committee to talk about the preparations for winter and are going on to talk about that further. So I think we are very supportive of the work that's been done by the whole system at the moment of into winter plan, and are keen to support and encourage colleagues about how we strengthen our plans for winter so that we can maintain the performance we've got through a period that's always going to have high levels of demand. Our board has spent quite a lot of time thinking about the challenges facing outpatients and diagnostics with those rising weights that we're seeing, and it's clear that we're going to need to think very differently about how those pathways work, and are focusing quite a lot of time and attention of our transformation team in that area at the moment. And then the final thing I'd like to say is just to reflect our eagerness that we get to resolution on the industrial action, and that both sides reach a settlement as soon as possible, given the impact that that is causing for our patients and our staff through this period. And I'm happy to take questions from the board as we go.
Thank you, Andy. And I can see that John has a raised hand there. You've got a question, John?
Just a comment, Andrew, really. I mean, obviously, you've got a very difficult task on. I mean, not just you, but everybody working in the hospital. I'd be interested to know more, not now, but perhaps we can talk again offline or make another meeting about how you're going about prioritising the workload to minimise the impact on patient outcomes, and whether you've got any metrics that will capture the adverse impact on patient outcomes, because I think we need that. I mean, I'm a doctor, I've been a doctor for 50 years, and I could never go on strike myself. I think, you know, we need the data to show what the impact is on people, and you know, I don't think we've seen much of that, so it would be useful to have that locally as well.
Sure. I mean, I'm very happy, John, to talk about that further. Just to reflect to the committee, you know, weekly we do look at how we are prioritising our work, to make sure that we're prioritising the patients in most need. That we have a weekly focus on that, and also on our cancer patients, to make sure that we're doing the right thing for those. You know, in this report, and then at our board again, we have been spending an awful lot of time reflecting on how we're supporting patients and our staff through that time. But I'm sure that Katie and Janet, our medical director, and our chief operating officer, are happy to have a conversation with you further, John, about how we're doing that.
I mean, you know, there can be no doubt that this will impact on outcomes and on death. The issue is, how do you minimise that?
Yeah, absolutely. And you know, through our serious incident reporting, we are seeing an increase in datexes and incidents relating to long waits.
Yeah,
absolutely.
And later diagnosis and later treatment for cancer.
Correct.
And such. Yeah.
Correct.
Yeah. Thank you.
Thank you for your question there, John. And we've got Alice.
Andy, what's the impact of COVID now?
Oh gosh, Alice. So we have got more patients now in hospital. I'm afraid I don't have the numbers with me, but more than we had during the summer. I would reflect though that those are patients in hospital primarily for something else, but have COVID, rather than being in COVID, in hospital for COVID. Actually our ICU, the last time I was on call a couple of weeks ago, was not extended or busy. So reflecting that position.
That's reassuring. Thank you. Thank you, Chair.
Thank you. Do we have any other questions from colleagues? Nope, I can't see anybody. No, online. Thank you very much for the report. Really interesting reading. So thank you very much.
Thank you, Chair.
Thank you.
Thanks.
So we're moving on to agenda item 13, which is access to GP-led services in Berkshire West. That's a project summary, and Alice is presenting.
Thank you, Chair. I'm sure the members have been alluded to our paper that's in the pack. Just to make you all aware, this paper has come to you all just as an awareness about this GP access project that is taking place in Reading at the moment. Our plan is to understand what is the public's understanding about the new way of working and about the NHS app. This is based on the feedback we have had from the public that they have not been able to get an appointment. Equally, when we put out a survey in April this year, GP access was our top healthcare and health and social care priorities. So at the moment, what we have done is we have had discussions with the Primary Care Network Alliance about how we were going to do this survey. And so we are doing a focus-based survey in Reading in 5 different areas. So focus-based, their areas are north is Weller Centre, south is South Reading Hub, east is Wycliffe Warehouse, west is Alliance for Cohesion and Racial Equality, and central is the Risk. And also we're going to be going out to the vulnerable groups. The whole idea is to find out from the public has the new way of working doing well, or what changes are there going to be taking place. So what we want to try and do is get the public aware of this project so that they can come and have a conversation with us. So that is the ask. If the board can share this project as far and wide, you'll be really, really appreciated. Thank you.
Thank you, Alice. Do we have any? Oh, Andy has a question.
Yes, thank you, Chair. Alice, thank you. Not so much a question, but just an endorsement as a GP and a member of the Berkshire West Primary Care Alliance. We've encouraged all our clinical directors of the primary care networks to work with all their practices to engage with this initiative with Healthwatch. We see this as a positive step to get not only the patient view, but also share the way that general practice has changed. The change in general practice has been driven by NHS England requirements pre-pandemic. They were accelerated through the pandemic. And as we were just talking about the transitions that Royal Berks services are going through, thinking about the future state, general practice is also going into a change of going in as what it's going to provide going into the future. So I think, any effort to discuss with our public, take them on board with that journey is welcome. And thank you, Alice, for the work you'll be doing.
Thank you. Just to share with you that we've got a video that's also going out while we do the presentation by Dr. Amit Sharma, sharing the new way of working. equally an infograph as well to tell the public what it looks like. And, also making the public aware that not every practice has got the same pattern of working as well. So there's also that awareness. But so far, when we did it at the Alliance for Cohesion and Racial Equality, there were really interesting comments coming out. One of them was communication. So there's poor communication about the new way of working. So I do think that is going to be a big awareness campaign needing after our project when it finishes in possibly in November, and the report is going to be coming out in February, end of February.
Thank you, Alice. I completely agree with comments Andy made there. I really endorse this project. And I was going to ask, what can the board do to support you? So I think, as you say, to share and encourage people to participate. It's really important work. So thank you very much, and looking forward to you returning with further updates and reports. Yeah.
No doubt. Thank you.
Yeah, thank you very much, Alice. And if we move on, no, apologies, is there any other, have I missed anybody? Any other comments, questions? No? Okay, so thank you very much then, Alice. And moving on to agenda item 14, which is exploring the oral health of under 10s in Norcote, Church and Southcote. And again, Alice is presenting.
Thank you, Chair. I'm sure you've read the paper that we have shared. The whole idea of us going out to these three areas is because this appears to be the area that's been most affected by dental issues. So we have just started recruiting the connecting community connectors, and they will be trained by University of Reading, and then they will be out into the public in these three areas, trying to get feedback about what is the experience about dental care, and what has been the challenges that they've been experiencing. Equally, one of the things that we need to highlight is Reading Borough Council does not currently have an oral health strategy. So hopefully this project will highlight what are the issues that's been what will come out of the project, and then possibly put into this as a new strategy. So that's what our plan is. Hopefully this plan will end in August. The write-up will be in August next year.
Thank you, Alice. And I can see a hand up. I think, is it John? John.
Thanks, Alice. No, important initiative. I just want to ask you, in the light of the Labour Party announcement this week that they're going to introduce toothbrushing in schools, and there's been some negative publicity. I mean, I think it's early days to see how that's received, but I had some experience of that when I spent a term at the Fiji School of Medicine when I was a student, and it's normal in schools in Fiji for the kids to keep a toothbrush at school and to brush their teeth at school, and it works very well. So I'm a supporter, but it might be worth just getting some feedback on that when you're doing this work, on what the response is to the idea of school-based establishing the habit of dental hygiene in school.
I think that's a good one. But I think this is where we're in the middle of, we haven't started asking the questions yet. So this is a good opportunity for everybody to be partnering and helping with this project.
Yeah, good.
Thank you. Thank you, John. And Sarah?
I was just to note that at the next ACE committee, the ICB will be bringing a broader update on dental services, so not just focused on children, but children and adults. So we can have some further discussion there as well with the data.
Yeah, thank you. I can't see anybody else's hand up. Thank you very much for that, Alice. I mean, I will say I am councillor in Church Ward, so very pleased to read this, and I'm, like most people, very concerned about, concerns around lack of dentists. So, this is really important. So thank you very much.
Thank you, Chair.
So we're moving on now to agenda item 15, which is Community Health Champions Programme Update, and Martin is presenting.
Thank you, Chair. Yeah, I'm Martin White, consultant in public health at Reading Borough Council. A very brief update on the Community Health Champions, which is the development of the previous Community Vaccine Champion programme. And this report is asking the board to note that the work is progressing, the programme has begun, and we're working on building up the support for the network of champions. And to note that change from being community vaccine champions to being community health champions, it's going to be driving the uptake of the vaccine offer and the immunisation programmes, but also to develop health knowledge amongst communities and strengthen community actions and self-help, and a whole series of programmes to support the network. The recruitment process for the 3 posts has just been completed. One of them is tasked with finding further funding to try and put the programme on a more sustainable footing. The work has been carried out in partnership with some of our community and community voluntary sector partners. Not all have been involved, and I had an interesting conversation with Rachel Spencer the other day about this, and it's worth noting that there is further development to be done, and resources are there to ensure that goes ahead effectively. Yeah, so that's it in a nutshell, really.
Thank you, Martin. I'm not sure if anybody, any questions or comments? Oh, Andy.
Yes, thanks, Martin. We had a previous meeting where the community health champions was talked about, and that almost spurred on the idea when we had this opportunity to do the project for reducing health inequalities and deprivation, and trying to tie in that aspect of bringing volunteers already embedded in the community with these community champions into the project. Do we know if we're going to be tying them into the project, or are they going to be maybe used as the next steps following the outreach work?
Well, the aim is to tie them in, Andy. I think we've got to try and make sure they're not tied into everything, because everybody wants a piece of them. But there's potentially a network of up to 50 or 60 champions. 15 are engaged at the moment. So the work is to try and bring the others back into the fold. I've been talking with Bev, and as Sarah said earlier on, public health, I've been helping to develop that community wellness outreach, as it's known in Reading, and to plug the community vaccine or community health champions into that, and into the place-based pilot work as well. There's quite a lot of investment in communities in Reading at the moment, and we're having some meetings to just brief one another about that and to fine-tune some of the coordination. So yes, basically.
Thank you. Thanks, Martin. Rachel has a question.
I think Martin's answered it actually, but it was just to say that we're just shaping the voluntary sector role within the outreach programme, especially for the key voluntary sector partners. And part of that role will be identifying potential champions within their communities and then supporting them to join up with the Champions programme. So definitely it'll be connected up.
That's really positive, actually really good news. Thank you, Martin. I mean, it's really positive, and when you hear about the numbers of the champions, it's a wonderful achievement, and it shows real dedication to the champions themselves and their staff and volunteers. So all really good work. Thank you very much. If you're moving on, I haven't missed anybody, have I? No, I'm always checking on the teams. So moving on to agenda item 16, the seasonal Berkshire influenza campaign. And again, that's yourself there, Martin.
Thank you, Chair. This report again briefly outlines the seasonal Berkshire influenza campaign and the accelerated autumn vaccination programme. I brought it together with information that was provided by partners in the integrated care system. So the first part of it is about that, about the ICB and the vaccination programme and the arrangements that have been put in place. And then the second part of it is about how we're responding and local arrangements in Reading. It reminds everybody about what the eligibility criteria are for the accelerated autumn vaccination programme, which was brought forward to the 11th of September to get started early. There is a new variant. It's not designated as one of concern, but there's work being carried out to understand what the significance is of the large number of mutations that it carries. Yeah, we're promoting the importance of having a vaccine, accepting the offer as we have done in years gone by. So there are descriptions about the arrangements across the patch and accessibility, and ensuring that everybody's within reach of where the vaccine is going to be offered. There is also some ring-fence funding for inequality projects to ensure equitable access. There's 14 projects there because we've learned from previous years that we need to do extra work to promote the uptake amongst people who may not be confident about it or may not have trouble gaining access to healthcare services. And within Reading and Reading Borough Council, we've been standing up the reimbursement scheme for staff so that they can get a vaccine and then get support for the payment for it if they're eligible for a flu vaccine and are able to go out and get one locally. We've also got use of the previous stock of personal protective equipment to support that, and we've also been talking quite a bit recently in detail across the authority, certainly across adult and social care, about the promotion of good respiratory hygiene throughout the flu season. So that's the outline there.
Thank you, Martin. Do we have any questions or comments from colleagues? Andy?
I'll do my public health bit as a GP to say, please get your vaccinations if you're eligible. We've been doing a huge amount of promoting of vaccinations, and yes, the usual over 65s are very keen to have it, but it's always very hard work to get the under 65s at risk to come forward. There is a variability amongst practices, those that are doing co-administration of COVID and flu, just so that residents are aware. Not every practice is doing COVID as well as flu. Partly, can I justify it? The rather mixed messages from NHS England about whether COVID was going to be needed, when it was going to be given, initially being told it was going to be in October, then bringing it forward to September, and then all the complications with the IT systems actually in terms of recording it. There was too much disjointedness, and I think about 50% of practices in Reading are providing COVID vaccinations and 50 have chosen not to, because just the logistics of trying to keep up with the constant changes NHS England throws at you is being very difficult. So forgive those practices that aren't doing it, but if go to the practices and go to the pharmacies that are offering it, please. I don't know, Martin hasn't been able to give us the detail on the variant, but you just never know. I was listening to something on Radio 4 the other day from one of the developers of one of the vaccines. They're hoping there's going to be a joint flu and COVID vaccine in 2025. So this double vaccination is going to be with us for the next few years. Thank you.
Thank you, Andy. I can't see anybody else want to speak, so thank you very much. A really useful update, and you know, I think there's so much confusion, so I think this is you know, in the media in terms of, you know, who's eligible and the different variants, and so I think this is a really useful report, so thank you very much.
Thank you.
Thanks, Martin. And so we're moving on now to agenda item 17 is the Board YCB update briefing, and Sarah's presenting.
Thank you, Chair. You'll be pleased to know I'm going to keep this fairly brief and assume that the report has been read. So this is just our standard update on some of the key things that we've been doing as an ICB. And on reflection, a lot of this is actually, we were discussing quite a lot of this already, because a lot of what we're doing is a lot more integrated. So we might want to give some thought to how we do these going forwards. But really, it's just a summary in the paper. And if there's any particular areas anybody had any questions on, I'll allow people to ask questions, but I wasn't going to dwell on anything in particular on the update.
Any questions from colleagues? No. Okay. Thank you very much for your report. Thank you very much. And there's another one. So if we move on to agenda item 18, which is a Bob ICB annual report, July 2022 to March 2023. And again, Sarah.
Thank you. Similar position here. So this is our annual report summarising again the kind of the actions, outputs, and points of interest from our organisation. We wanted you all to have the pleasure of being able to read it, all 130 pages of it. I'm sure you've read it intricately. So if there are any questions on that, again, I'll be happy to take them, but I'm not going to go page by page.
Any questions from colleagues? I can't see any hands up just now. So are we happy to note the report? Yeah. Okay.
Thank you.
Thank you very much. Thank you very much, Sarah. Okay, that takes us to the end of the agenda. And so the next thing to arrange is the date of the next meeting, which is the 19th of January 2024. And so thank you very much. That's been quite a long 3-hour meeting. So thank you for your patience and thank you for your input, everybody. Really useful and really interesting subjects as always. So thank you very much, everybody. And thank you for those attending. Have a lovely weekend, everybody. Bye.